How
Webinar is being
exciting.
recorded. Continue.
Welcome, everybody.
Hi.
Hi, Leah Naren.
Hi, how are you? Are you ready to get this started?
I am really ready to get this started. Super
All
excited.
right.
I'm loving watching these numbers go up of our participants. This is just, when we started this back in, I don't know when we started talking about this, Leah. It was like in the spring for sure.
For sure. It seems like forever ago now, but I know it was. Time flies.
A lot has happened.
Okay, well, I don't want to get you behind, so here I go. Hi, everyone. My name is Leah Narens, and on behalf of the Planning Committee and someone living with MS, I'm so excited to welcome you to the first virtual Holistic Health and Wellness Forum for MS. Well, that's a mouthful. We hope that this program will help you improve your physical and mental well-being, especially during this difficult time. The topics and presenters were specifically chosen for their areas of expertise, and our hope is that they will provide you with new and valuable information that you can apply to your daily life. Now I would like to introduce you to Mindy Eisenberg, the director and founder of Yoga Moves MS. And I would like to personally thank Mindy for her hard work and her dedication to improving the lives and well-being and mental well-being for people living with MS. And to you, Mindy.
Thank you, Leah. Just a little bit about Yoga Moves MS. We are a nonprofit 501c3 organization, and we have grown to be a supportive community of students, teachers, and volunteers. For over 15 years, this program has evolved into a movement with the common goal of improving lives for those with MS and their families and their care partners, all equally important. Yoga serves as an umbrella for a way of life that includes healthy lifestyles. Therefore, Yoga Moves presents this our first virtual Holistic Health and Wellness Forum to empower those impacted by MS and neuromuscular conditions with information about a range of integrative and holistic mind-body strategies. The event is an opportunity to learn about healthy living and wholesome options that complement your traditional medical care. We're thrilled that so many are gathered with us today to connect as a community from around the country. Your participation is greatly appreciated. We know your time is precious, and we're so happy that you're here today with the knowledge that you gain from our expert speakers. We hope that it will contribute to your health. We hope that it will help you turn into your inner wisdom and strength that is already within you. Please take this information back to your communities. Give us feedback about what you'd like to see for future events. Give yourself a big hug, namaste, from the Yoga Moves community. I want to thank our amazing sponsors. We couldn't do it without them. Our platinum sponsors, Biogen and Bristol Myers Squibb. Our gold sponsors, Sanofi, Genzyme, Genentech, and Meyer Specialty Pharmacy. And silver sponsors, EMD Sereno and Optum. Make sure you look at the exhibit hall, and there's information about the presenters and exhibits from our sponsors in there. And thank you to all the friends that helped to spread the word about this event. You're going to see Memorial Healthcare Institute for Neuroscience. You're going to see MIND, Michigan Institute for Neurological Disorders. You're going to see the Michigan Neurology Associates, the Missing Link, which is MS-ing Link. You're going to hear from Gretchen very soon. The Boster Center for MS, Brain Speedball, wait till you meet Trent McIntyre, MS Views and News, thank you so much, and MS Insight for spreading the word. Now, make sure you use the chat to ask questions for the speakers. We have people, we're going to look through the questions, and with time allowed, we're going to ask questions of the speakers from you. This is your chance to interact. You can come in and out of the webinar. You can sign on and off once you have the link. We do have a help center going if you have any questions. We're going to be asking trivia throughout the forum. And the first one to answer the trivia question gets a prize. And just to give you a little hint, one of them is that brain speed ball. So let's breathe together. Let's begin. Have a wonderful day. Give yourself a big namaste hug. And now we are on Dr. Gretchen Hawley. Welcome, Dr. Gretchen. She's a doctor of physical therapy and MS certified specialist. After graduating from Simmons University in Boston, Massachusetts, she developed an MS physical therapy program alongside two of the city's top MS neurologists. Dr. Hawley utilizes the concept of neuroplasticity in her online MS wellness program, the missing link to help her clients reduce fatigue, get stronger, improve their balance, and walk better. Her members feel more energized, empowered, alive, and more like their normal self again. Dr. Hawley has been a keynote speaker at several MS conferences, lectures frequently for MS support groups, and continues to keep herself up to date on the newest and best MS practices by attending the MS Consortium each year. Dr. Hawley resides in Buffalo with her dog, Finn. Welcome, Dr. Gretchen. So excited to have you today.
Thank you for having me. I am so excited to be here, and thank you, a huge thank you to Mindy and everyone behind the scenes for putting this on. Virtual events can be chaotic and brand new to a lot of people, attendees as well, and I'm just so honored to be part of this, so thank you for having me. So we're just going to jump right into the presentation, and as Mindy said, if you guys have any questions, there is going to be a few minutes at the end for a Q&A. So we're going to be talking about physical therapy for multiple sclerosis. And I am so passionate about this topic because it is very different than physical therapy for orthopedic reasons like knee pain, back pain, post-surgery, and it's very different than general strengthening exercises. And I can't tell you how many times I've heard the statement of, well, I've tried PT, but it didn't work for me. And it's likely because it wasn't PT specific for multiple sclerosis. So what we're going to be going over in this presentation are a couple of things. And on the next slide, I'm going to show that to you. So the first thing that we're going to talk about is learning the how. How is this actually possible? Because another thing that I hear frequently is, well, I have a progressive disease, that means I can't get stronger. And that's actually not true. So I want to teach you the how first, and then we're going to go into actual exercises that you can do. I'm going to give you 3 of them, so I hope you're ready. And then the last thing is the guidelines, because not only is there a very specific way that we should be doing the exercises, but there are specific guidelines on how you should be doing those specific exercises for MS. So let's jump right on in. The first thing that is extremely important to know, that most of you likely already know, is that there are a few things that need to happen in order for a muscle to move to begin with. So the very first thing is your brain has to have the thought of movement. It has to either be a reflex, like an involuntary reflex, or you have to have the actual thought of reach forward and grab that water bottle. So it has to come from your brain first, then it travels through the nerve, and if there's any issues at the nerve, then that's where the limitation may be coming from. And then it gets the muscle to fire. So there could be issues at each of these levels. The issue could be in the brain, where your brain's not sending the message. There could be an issue at the nerve level, where the brain sends the message to the nerve, but the nerve is working in a faulty way. Or the issue could be at the muscular level. As we all know, with MS, the issue is at the nerve level. So on the next slide, we're going to talk about neuroplasticity. And I hope you know what neuroplasticity is already. If you don't, you're going to hear it again for the first time, but this is something I will always include in my presentations, even if it's a million times, because I truly believe that neuroplasticity is it's the reason that people with MS actually can get stronger and improve their balance. And you need to fully understand it in order to be in order to not get as discouraged with exercises. So I'm a firm believer that everyone should know neuroplasticity so well that they could explain it to someone else. So the way that I like to explain it is that it's the ability of our brains to create a new pathway or strengthen an existing pathway to make a movement occur. So as I mentioned from the last slide, in order to improve muscle strength, it has to start from the brain, go through the nerve, and then extend to make that muscle fire. So I have a water bottle right here. So I want to show you an example of what I'm talking about. Let's see if I can show you my water bottle. Okay, so here's my water bottle. So neuroplasticity means that my brain, maybe right here, I'm going to use this hand. Let's say this part of my brain is what needs to fire in order for me to reach forward to grab that water bottle. So if this part of my brain says, okay, Dr. Gretchen, reach for that water bottle, it's going to send a neural pathway here, and maybe my arm doesn't extend at all. Like it meant to, but it just didn't. So I attempt this movement a second time, and I try to reach for it. My brain isn't going to use that same pathway because it didn't work the first time. So on my second attempt, my brain might send this type of pathway. It still didn't work to go further. On the third try, maybe some zigzags. There's a million different ways to get from point A to point B to extend my arm. But the only way to find the way from point A to point B that's going to work is to keep trying. Our brain is not going to use ones that didn't work. So every time you try to do an exercise or try to do a movement, your brain is going to try to find a different way to get from point A to point B. So let's say on my 200,000th try, my brain does maybe a couple different swirls there, and then I'm able to reach for it. Then that means that, okay, we just found a neural pathway that works. So every time that I am going to extend or attempt to extend my arm, my brain is going to use that same pathway, and then I can extend. And keep in mind, this extension, it's not like once your brain finds it, it's going to be perfect and, oh, now this is easy for me to grab my water bottle, but it at least has a pathway that's working. And then every time you practice this movement, it's strengthening that pathway that it found. Similarly, if there's a movement that maybe you can do already, maybe you could reach a little bit, but it's hard and maybe it feels like a ton of bricks, but you can get there, you have a pathway that's working. So for you, every repetition that you try, you're strengthening that pathway that's already there. So this truly is the reason that anyone with MS can get stronger. And I'm using the example of my water bottle right now, but this is true for if you have foot drop or difficulty lifting your leg up to walk. If you have zero movement right now, practicing the movement will encourage your brain to get this neuroplasticity firing so that you can actually find a new pathway. Or if you do have some movement, you're going to be strengthening that pathway that's already there. So this can be good and bad. It's so important, and I'll talk about this more on a different slide, but it's so important that you have good quality, because if I'm reaching, I'm going to put this in front of me now. If I'm reaching for this water bottle and my goal is to reach forward like this, but instead I'm reaching, oh, you can't see it. I'll move it there. But instead of reaching forward, this happens. Then every time I reach for something, my arm's going to move in this weird way. Another example that I like is if for some reason, maybe let's say we're working on feeding ourselves with that coordination. If this is the movement that I want, but every time I practice it, or more times than not, I do this, because that's the way my muscles are working, then when I try to feed myself, my food's going to go over there because that's the movement that I'm practicing. So you have to practice with the exact movement that you are looking for. Okay, so we can move on to the next slide. I hope that makes sense, because it is extremely important. Actually, one last thing about neuroplasticity. We don't know yet how long it takes to occur. So that is one thing that one question I get asked a lot is, okay, well, how long do I need to do this before neuroplasticity kicks in? And unfortunately, we don't know yet. It's not in research of if you do exercises 5 days a week for 60 minutes each time for 6 months, then it'll kick in. For some people, it kicks in with, I would say, within a couple of weeks, I've noticed. Other people, it's a couple of months or a couple of years. So you really have to just trust that this is happening behind the scenes and that over time, you will benefit from it. The main thing I want to point on this slide is that BDNF, also known as brain-derived neurotrophic factor, this is a protein that is released in our bodies when we exercise. And this is a protein that supports the survival of existing neurons and also encourages growth of new neurons and new pathways. So it goes hand in hand with neuroplasticity. And it also has been shown to have cognitive improvement and alleviate depression and anxiety. So that's why when people exercise consistently, they feel so good. We have this endorphin rush because of this protein. And lastly, our brains actually have a reduced inflammatory response when we exercise for at least 20 minutes, which I love when this research came out, because usually people were thinking, okay, I have to exercise for at least 30 minutes, if not 45 minutes or an hour in order for this to be effective, but that's not true. We only need to exercise for 20 minutes to reduce the body's inflammatory response. So let's move on to the next slide. Can you move on to the next slide? There we go. Okay, so this is also extremely important. The biggest difference between exercise, like from a personal trainer or just exercise that we learn growing up, versus orthopedic physical therapy and MS-specific physical therapy, is that MS-specific PT, it has to be functional exercises. When you are exercising, if you're just doing a general strengthening exercise, then when you have MS, it doesn't always have the same carryover. So I don't know if any of you guys have been to physical therapy before, but a very common and great hip flexor exercise, which hip flexors are the muscle you need to lift your leg up to walk forward or to shift around in your chair, is you need to be able to lift that up. So in regular PT, people will lie on the ground and you have one knee bent, one leg out straight, and you slowly raise it and then slowly lower it. Then slowly raise it and slowly lower. And it's a great exercise. However, what people with MS often experience is you could get really strong with that exercise, maybe even 5 out of 5 strength, but you go to stand up and use your hip flexor strength and it's non-existent, it's not there. And that's because that exercise is not functional for walking or for any type of standing or sitting movement because you're lying down. So functional exercise means you pick an activity that's hard for you to do and you break that down into a bunch of different exercises. So I'm going to show you on the next slide, but an example of a non-functional exercise, if your goal is walking, would be this recumbent bicycle. All of my clients love the recumbent bicycle. I love it as well for other reasons, but one thing that I hear a lot is, I've been biking, I've been on the recumbent bicycle or on a stationary bicycle for a long time now, and my walking isn't any better. Well, that's because you're biking, you're not walking. Biking is a helpful exercise if your goal is to bike better, but walking and breaking down those walking exercises would be a helpful exercise if your goal is to walk better. So you really have to think of, what are my goals? If your goal is to stair climb or climb stairs better, then we need to work on breaking down stair climbing. So that's one thing that I would encourage you to do, is figure out what is it that you want to improve, and then we need to break those down into exercises. So let's move on to the next slide. And this is always something that seems to be like mind-blowing to people. So and actually let me show you this in person. So if you can stop sharing the screen, let me back up, just so I become a little bit bigger. move my chair over to this side. So one thing that a lot of people tell me is that they want to improve their walking, but what they don't realize is that walking is more than just one activity of walking. So basically, you need to have balance, you need to have strength in so many different muscle groups. So if I back up here, I hope you can see me. Actually, I'll bend this down. Okay, so in order for me to take a step forward in this direction, what I need to do is I need to shift my weight forward, bend my knee, swoop my toes up, bring my knee up to the ceiling, straighten my knee, put my heel down. I don't know if you guys can see my feet, but my heel is down. All while that was happening, I was standing on one leg. So that's 7 different things, meaning if you have a goal of walking better, all of those 7 things should be something that you work on. And you might feel like some of those are really easy for you. The kicker with walking is that if one of those 7 things isn't working well, your walking will be off. So that's what I mean by a functional exercise. If you have a goal of walking better, you now have 7 exercises that you can do. And then work up to walking, putting them all together and actually walking. But it wouldn't be exercises like the straight leg raise, like I demonstrated or showed before of lifting up, lifting down. That would not necessarily have the same level of improvement for you as these exercises. Okay, we can move on to the next slide. So we have 3 exercises right now. So what I want you to do is make sure you are in a comfortable position and you have a little bit of space around you. So this first one that we're going to do is a strength exercise. This is one of my favorite exercises that I personally feel anyone with MS should do. And even if this is easy for you, or even if this is so hard and there's no movement, everyone should be doing this. So with this exercise, I'm going to show you again as well. With this exercise, what you're going to do, ideally sit up tall, core muscles are tight. You can hold on if you need to. Slowly lift one leg up as high as you can, and then lower it down. And then the other leg all the way up, and lower it down. If this is too challenging for you, you can actually recline backwards a bit, and that makes it a little bit easier, and up and down. So keep going with this exercise. I'm going to continue talking to you and explaining it, but I want you to keep going. The reason this exercise is important is because when we're walking, this is the same movement. You're just sitting instead of standing. So eventually you might do this in a standing position. Or if you need to get into a car or out of a car, you have to be able to lift your leg up and over and then up and out. This exercise strengthens your hip flexors, which we use in so many things throughout the day. And one thing that I want to point out about this is likely you might have a side that is weaker than the other. Excuse me. Let me take a sip of this water now. So it is very normal to have one side of your body that's weaker than the other side. So if you have a weaker side and there's no movement right now, keep trying. Your brain, what I want you to think about is your brain, every time you attempt, even if there's no movement, try to do this exercise, your brain is trying to find a way to get from here to your hip flexor. And over time, research shows that that will happen. And again, it's not going to be miraculous. It's not going to be a huge movement, but it might lift a centimeter, and then 2 centimeters, and then 3 centimeters. So it will improve over time. And if you do have some movement, so maybe it does lift, but it's not as good as the other side, and it's heavier and it's harder, keep practicing. You have a pathway that's working, so let's keep it strong and get it even stronger if possible. So this is one of my favorite exercises. We'll move on to the next one. And the next exercise is balance, because as you just saw me practice, all while those things were happening, as my one leg was coming up and through, I was standing on one leg. And what what I hear a lot is, oh, well, I have an assistive device, so I don't need to stand on one leg. And that is true. When you have an assistive device, you do have, excuse me, you do have something helping you, but we should never be putting a lot of weight through our assistive devices. They are not meant to withhold our full body weight or even most of our body weight. So if you are doing that I would consider as a safety risk or a fall risk. And the better your single leg balance is, even if you are holding on to something, the better your walking will be, the safer your walking will be. So this exercise might be too challenging for some people. And I also hate that he's using this chair in this photo. Please never use a chair like this for balance. Make sure it is something sturdy that will not move. The goal of balance exercises, the goal of what you use to help with your balance exercises, is that if you do feel a little bit tippy or like you might fall over, whatever you're using to help out will prevent a fall, whereas this chair would just fall right on over. So for this exercise, if you are practicing, again, not the best chair, this is a swivel chair, don't use that one. However, actually, we'll use this. Hold up tall, core is tight, and if you can, take one leg off the ground, one leg is down, and then let go with one hand, another hand. If that's too wobbly, maybe keep a couple fingers on. You don't just want to jump to, okay, hands are off and I'm standing on one leg. And if that's too challenging, there's so many other ways that you can get there. You could try standing with your feet together, feet apart, somewhat of a staggered stance. All of those positions are helpful for walking, as well as for just things like standing and reaching for something. We need to be able to balance well in order to not risk falling over. So this is another one of my favorite ones. On the next slide is one for proprioception and coordination. So a really important thing with walking too is to put your foot where you want it to go. I can't see your hands right now, but you can participate anyways. By a show of hands, how often when you walk do you actually put your leg where you want it to go versus crossing over or crossing too far out? I see that all the time, where instead of one foot staying in the right alignment, we'll cross this way or this way. And it's often the issue where people say like, oh, people think I look like I'm drunk when I'm walking. This coordination and proprioception is the issue there. So she's standing, but I normally like to do this exercise sitting on the ground. So not sitting on the ground, sorry, sitting in a chair. So what I want you to do is sit up nice and tall if you can. And you can't see my feet right now, but I happen, luckily, to have a feather on the floor right there. However, if you have a design on your floor, or if it's tile floor or hardwood floor, pick a point on the floor. Doesn't matter what it is. It could be a penny, it could be something on the carpet, whatever it is. And I want you to lift your leg up and tap your heel on that item, that thing that you want, that you say you touch, and then bring your leg back, and then the other leg, and then bring the leg back. Make sure it's not something that's too far away from you. It needs to be relatively close, and bring it back, and just practicing this coordination of my heel is going to go right there and making it go right there. Ideally, with this exercise, you would use something that's small. Maybe it is as small as a penny, because the more precise, the better. But for some people, that's too hard at first. So you could even use something like your phone. Like, it doesn't have to be super small, but just getting your brain to practice putting your foot forward and then bringing it back exactly where you want it to go. All right, next slide. Okay, so the newest guidelines, write this down if you have pen and paper. So first of all, aerobic exercise first. So doing aerobic exercise before you do these other MS-specific exercises has been shown in newer research to actually prime your brain for neuroplasticity, which is amazing. When I first heard this, I literally I like almost jumped up with joy. I'm like, are you kidding me? Like, not only is neuroplasticity possible, like you can actually get stronger, but you can improve your odds of that by doing aerobic exercise first. And aerobic exercise doesn't necessarily mean running on a treadmill or even walking on a treadmill. There's tons of ways that you can get aerobic exercise in without fatiguing your legs. The next one is high repetitions. So with neuroplasticity, the only way to get it to work and to improve the neural connection and improve the muscular strength is high repetitions. So over and over again practicing. And then also perfect quality, because we want our brains to remember the good quality rather than bad quality. So we have to be doing more perfect quality ones, which requires lots of rest breaks. So these are the things that you should be implementing when you're doing your exercises. On the next slide, I have a couple of other guidelines. So one thing that a lot of people tell me is, I just don't have time to exercise, or I just can't do all of my exercises. And this first line that I have here, distributed is equal to mass. What I mean by that is research is now showing that exercising throughout the day, 5 minutes here, 5 minutes there, 10 minutes here, is just as effective as exercising all at once. So if you have 5 minutes here, 15 minutes, 10 minutes, just sprinkled throughout the day, do your exercises in that time. It's just as effective. The second thing is that a variable environment is better than constant. I had a perfect example of this where I was working on standing up and sitting down from a chair with one of my patients, and she did it perfectly in the PT clinic, and someone, or her husband, came to the session one time and said, Dr. Gretchen, I don't know what you're doing that's magic in here, because I see her do it with you and she's perfect, but we go home and she's not doing it well at all. And as soon as he said that, I was like, we're literally doing it in the same room, in the same chair. So from then on, we practiced in all of the different rooms in the PT clinic. There was a neurology clinic across the hall that I worked with the neurologist there, so we'd go over there. We sat in their waiting room chairs. We would practice everywhere. Variable environment is better than always doing it in the same place. And lastly, a random order is better than blocked order. So for example, those 7 things that I mentioned earlier for walking, you wouldn't want to practice them all in the same order. You'd want to mix it up a little bit. Random is better than always practicing in the exact order that it belongs in. Okay, next slide. So how to be consistent, because this is something that a lot of people struggle with. You might know what to do, and now hopefully you do feel a little bit more clear on what you should be doing, but consistency is really where all of this comes into play and where you'll notice the long-term benefits. So one thing that I want to mention here is that research does show that if you have MS, you should be exercising 5 to 6 days a week. However, there is also research that shows 2 days a week is still enough to get some improvement. And the reason I want to point that out is because so many people will say, well, I didn't exercise at all yet this week, and it's already Friday. I guess I shouldn't do anything. I'm not going to get better at this. So just keep in mind, 2 days. If you get 2 days, be proud of yourself and try to improve from there, but 2 days still can show improvement. The next one is that make daily movements exercise. If you don't enjoy exercise, or if you don't feel like you have time to do all of the exercise, if you have to grab something from the fridge, squat down. There's an exercise for you. If you need to practice balance, maybe as you're waiting for your coffee to brew, you can practice balance. If you need to practice standing up and sitting down, every time you stand up and sit down, then use that, go slow, and use that as an exercise. If we could go back to the last slide for a second. Sorry, there were 2 others. The third one is to start with one exercise. So if you feel overwhelmed, you have a lot that someone has been telling you to do or that you want to do, just start with one. Pick your favorite one. Maybe it's the easiest one, and just do one exercise each day or most days. And then once you're in a routine of that, add a second one, and then add a third one. And then the last note on this slide is just to make a plan. If you are someone who's just like, I'll exercise at some point today, you're less likely to stick to it than if you say, I'm going to exercise at 2 p.m. today. And with MS, obviously that's really hard to do. 2 p.m. might come around and you're just not feeling so hot, but it will at least get you started in a direction of making a plan. And if consistently around 2 p.m. isn't great, maybe 11 a.m. or 4 p.m. So everyone's going to be different, but attempt, if possible, to make a plan. Okay, now we can go to the last slide. And I do see some questions coming through, so we'll be going through those. There are lots of there's so many resources out there in order to get more of these exercises. This is not a long enough presentation where I can give you guys all the exercises. I do have a YouTube page. I do have an Instagram, Facebook, all of that. So hopefully you guys can find those as valuable resources. And let me pull up some of these questions. Dr. Gretchen, do you do consults for patients in the UK? So I am a licensed physical therapist in Massachusetts, New York, and Maine, all in the United States. So legally, I am allowed to treat patients in person or via telehealth in those states. So not in the UK. However, that is one reason that I actually created The Missing Link, my online MS wellness program, because that is a way that I can put all of this education and exercises and everything together, and anyone can use it all throughout the world. So that might be something that you can look into. Let's see, foot drop exercises. So my favorite foot drop exercise, I'll use my hand just to show you. If this is my knee, this is my heel, these are my toes, so slightly use your imagination, but I think you can tell. Foot drop, obviously, is when your toes drop, and that's exaggerated, but you know, when your toes drop or you don't have as much strength. So one question that people ask me a lot is, if there's one thing that I should do, what would it be? And my answer is always, do the thing that's hard. So if for you, if it's foot drop, lift it up. Practice lifting, practice doing the thing that's hard. This is my favorite. It's so simple, but it's my favorite exercise for foot drop. All right. So I'm going to take one more question. Sorry, I know I talked for a while. My email is open. Please email me if you have any questions. Let's see. Thoughts. Can I send resources? Yes, I can share this slide. Someone is hiking, partial numbness in my feet and my toes. I think that going on hikes and very textured paths helps by stimulating my feet and toes. I notice a sensation more because it is varied. Yeah, and you know, today's presentation is just on exercise, strengthening exercise. There are so many different ways of working with your body, like this person's saying too, getting on different surfaces, rough surfaces, uneven surfaces, as long as it's safe for you. There's sensation exercises, there's stretching, there's so much. So neuroplasticity occur if I've been numb for. Neuroplasticity isn't for numbness, it is for strengthening. All right, guys, I'm going to stop there. If you can, shoot me an email, reach out to Mindy or some other way. I'd love to answer other questions, but my time is up. Thank you so much for listening, and I hope you got a lot out of it.
Thank you so much, Gretchen. That was amazing. We're getting all kinds of feedback on how wonderful you are. And if your questions haven't been answered, we will look through the chat. We will get them to you. We promise. Now on to Dr. Amy Sullivan. So excited to have her. She's the Director of Behavioral Medicine, Research and Training for Cleveland Clinic Mellon Center for MS. Dr. Amy Sullivan is board certified health psychologist and Director of Behavioral Medicine Research and Training at the MS Mellon Center. She's an invited member of wellness research through the National MS Society. She and her research team are the 2015 recipient of the Robert J. Herndon Award for Most Outstanding IJMSC article. Dr. Sullivan was also the recipient of the CPA Outstanding Early Career Psychologist Award and was named an extraordinary graduate of St. Bonaventure University, where she played Division I basketball. In addition, she's passionate about physician self-care, burnout, diversity and leadership, and psychological health, and is the director of engagement and well-being in the Neurological Institute, where she works to improve physician well-being in her institute. She's also the co-chair of the Women's Leadership Team. She is the director of the FRAME Education Program for the Internal Medicine Residency Program, where she works to help students understand their worldview, resilience, and emotional intelligence in the practice of value-based medicine. Her presentation is Managing Our Emotions During Uncertain Times.
Well, thank you so much, Mindy, for that wonderful introduction. And I also want to thank you so much for inviting me to participate in your real star-studded, empowering day of education. It's so exciting to be here. And I also need to share a bit of gratitude to Dr. Boster, who I know suggested me and really believes in the holistic treatment approaches for people with MS. So I'm just honored to virtually be here today among some of the greatest minds in MS care. I do not see my slides up, so I'm waiting for those to come up.
They're coming.
There they are. Wonderful, wonderful. All right, so I wanted to start by just giving you a little bit of information in terms of why I decided to do this presentation on managing our emotions during uncertain times. So I think we all feel the same way, that the year 2020 has been unprecedented in a number of ways. In 2020, there have been natural disasters, there's been a major political divide, therefore a human divide. I feel like the human divide is at an all-time high, and we're in a global pandemic. 2020 has really changed our thoughts, our emotions, and our routines. Limited social interactions have really shaken our sense of safety and perhaps increased anxiety, sadness, disappointment, hopelessness, and grief. These are all very normal responses, but they're very difficult to manage. So taking care of ourselves, especially in utilizing holistic and wellness approaches, is essential in helping find normalcy and well-being. Go ahead. And you will see this slide again, but I really feel that this is important to conceptualize what my talk is about. So these are our pillars of well-being. They're activity, both mentally and physically, nutrition, and rest, meaning both sleep and shutting down our sympathetic nervous system, which is our anxiety and our response to stress. And instead learning how to turn on our parasympathetic nervous system response, so rest, relax, and recover. And this is something that I'll show you throughout the course of our presentation today. Go ahead. Go ahead. So I wanted to show this slide because I think it's really important to understand the high prevalence rates of mood disorders in our MS population versus the general population. So our MS population is in the orange, and the general population is in the green. And so what you're seeing, the first is depression. And so depression occurs in about 50% of MS individuals, and that's about 3 to 4 times the rate of depression in the general population. Next is anxiety, and I think anxiety is very difficult to measure because anxiety can be measured via state or trait, but in this study I found anxiety was at 36%. We have adjustment disorder at 22%, bipolar disorder at 13%, and psychosis at 3%. So just important to share the high prevalence of mental health disorders in the MS population. And remember, these are disorders. So this does not mean, this is not accounting for just symptoms of depression or anxiety. Okay, go ahead. So what we're looking at now is emotional health during a pandemic. And so as I had shared earlier, I think it's very normal to have waves of emotion. So at some point people will say to me, well, I feel really grateful today because I'm healthy or because I have a job. And then in the next breath, they're feeling very uncertain. They're overwhelmed by information. They're sad from social distancing and not seeing people that they typically want to see, feeling isolation and loneliness, which is one of the major things that I'm seeing with my patients with MS. And so we then created a virtual support group that has gone over very, very well in terms of helping to connect our patients to each other during this very uncertain time. There's also economic certainty. We're noticing that there's decreases in well-being, and again, there's that word again, and psychological health. There's also increases in uncertainty, depression, anxiety, and stress. Go ahead. And so when we understand that mental health issues, they can really add to the burden of MS, and this can impact mood, relationships, function, quality of life, medication adherence, and decision-making, and at times suicidal ideation. Go ahead. This is one of my favorite pictures. So what we understand about stress is that it doesn't just impact your mood, it can impact your entire body. And so what this picture is showing us are the effects of stress on the body. So stress can impact our mood, our cognition. It can impact our cardiac system, so blood pressure, heart rate, cholesterol, and the risk for heart attack. The immune system, so there's a reduced ability to fight and recover from illness, which is really important now. GI system, so stomach cramps, reflux, and nausea. Our sexual system, so loss of libido, lower sperm production, increased period pain for women. Our bones and our joints, so aches and pains in the joints and the muscles, and lower bone density. Okay, go ahead. So I think it's important for us to understand that when we see that our mood is really starting to impact us, it's important to seek professional help. So what I mean by that is when we see that there's loss of interest in things that one used to enjoy, that our mood impacts everyday activities such as being with our family or our jobs, or how we respond to events, or managing our diagnoses and our health. When it starts to impact function, quality of life, and relationships, again, it's time to seek help, and certainly when you have suicidal ideation. Okay, go ahead. So when I think of treatment considerations, I really believe in the multidisciplinary approach to managing our MS patients. So we really manage the whole patient. And so this really reminds me of the parable of the blind men and the elephant. So many of you may know this parable, but it's really one of my favorites. So this parable states that there were blind men who saw an elephant for the first time, and each of the blind men felt a different part of the elephant. Thus, their truth was in what was being, so what they had felt and what they had experienced. So one blind man felt the trunk of the elephant and said, well, this certainly is a snake. Another felt the leg and said, no, this is a tree. Another felt the ear and said, this is a fan. And another felt the tail and said, this is a rope. And finally, another felt the body and said, this is a wall, and so on and so forth. And the men got into a large argument about what their experience was and therefore what they believed. And so a wise man comes in and hears them arguing, and he shares with them that all of their experiences are correct, but that they needed to put their experiences together to truly understand the elephant. And this is really a similar belief to how I believe we take the best care of our MS patients, by each provider being a specialist in their specific area and putting together what we completely understand about the patient and the person. So these are some of the things that we do in behavioral medicine. So behavioral medicine is a form of treatment that focuses on the psychological nature and needs of the patient. So some of the things that we do are called cognitive behavioral therapy, and I will talk a little bit more about this in the next slide. Another thing that we focus on is the grief acceptance and adaptation model. And so this helps us to kind of conceptualize the MS diagnosis and the MS path for the patient, because initially they are diagnosed, and then maybe they start to understand the disease and start to accept where they are with the disease, and then maybe they have a relapse, and it's time for them to kind of go through this acceptance and adaptation model again. We teach behavioral therapy, and that's really important for people who have stress, so shutting down that sympathetic nervous system or that fight or flight nervous system. As I shared earlier, we have several group therapy sessions that are now all virtual. They range from a men's MS group to a young professionals group to a caregiver support group to an MS process group. and we make use of community resources. Go ahead. So I wanted to spend a little bit of time on cognitive behavioral therapy. So many of you may have heard this before. So cognitive behavioral therapy, or otherwise known as CBT, really focuses on the relationship between one's thoughts, emotions, and behaviors and how they all intersect on mood. So it's relatively short in terms of treatment duration, and there can be different modes of delivery. So as you know, the world has changed, we've also changed the way that we deliver. And I would say up until a month ago, 100% of our care was delivered virtually. Now we have about 2 patients a week that want to come in, but most of our care is delivered virtually. And we can incorporate some behavioral strategies such as relaxation, stress management, breathing, visualization, and mindfulness techniques and interventions. And it can also be delivered in group format. So I'm a big fan of cognitive behavioral therapy and creating a tailored approach for each individual patient. Okay, go ahead. I think it's also important to share a little bit about pharmacotherapy. So some of the pharmacotherapy classes that we use for mood disorders are the SSRIs, and these are really recommended as first-line treatments because they have the fewest side effects. There are some potential medication interactions, and there can be some side effects. The SNRIs are recommended before the use of TCAs and MAOIs, and there are also some potential medication interactions, but these are used for people who also have pain in addition to mood symptoms and anxiety. And then there are the benzodiazepines, and these are widely used as a fast onset of action, and they have proven effectiveness. However, there can be some side effects associated with those, such as excessive daytime sedation and confusion, and it can lead to dependence. Okay, go ahead. Okay, so now we're going to focus a little bit of time on specific recommendations for coping with anxiety. So first and foremost, wellness is imperative. And so I promised you that you'd see that image again. What's really important is for us to learn how to maintain a healthy diet, to move or exercise regularly, to have a routine, to practice some form of spirituality if that's something that's important to you, to understand full well-being, and so that includes psychological well-being, and to sleep. Okay, next. My second recommendation is to take a break from media. I think it can really draw us in, but it's really important to know that it can stimulate you as well. So it's important to disconnect from the media. It's important also to stay informed from a trusted source. So maybe one 30-minute block in the AM and one 30-minute block in the PM, but not to have it on all day long. It's also important that we protect our children and our elderly from incorrect information or overwhelming information, and that we provide our children with age-appropriate information. So a lot of information is coming out in the news, not just with regards to COVID, but there's been other things that I think are really important for us to monitor and protect those who are the most vulnerable. Go ahead. Number 3 is getting sleep and resting and recharging. And so one of the things that I suggest is not watching something that stimulates you. So for some, it's news media and within a 1-hour time frame of going to bed. Limiting stimulants, so such as alcohol and nicotine before bed. Consistently staying on your normal sleep-wake cycle, so that includes the weekends as well. Understanding that if worries creep in and create insomnia, you can have a worry journal right next to your bed. So reaching out, grabbing that worry journal, and just writing down your worries and dealing with them in the morning. And then perhaps having a wind down time with a bedtime routine, with a bath or a cup of tea. Okay, next. This is probably my favorite. So connecting with others. So in a safe manner, connecting with others. So reaching out to
Your
family.
Your name is?
Hi.
What's your name?
Can you mute that,
Amy?
please?
Hi, I'm Leah.
Hi,
Nice to
can
meet
you guys mute that line? Thank you. Particularly those that we know are isolated. So maybe sending a card, a FaceTime, a Skype, and just becoming creative and connecting with those that are really important to us. All right, go ahead. And finally, we're going to focus on stress management techniques. So breathing techniques, visualization, mindfulness meditation, if necessary, seeking mental help if worries, anxiety, isolation, grief become unmanageable, and creating coping projects. So things that you can do maybe with family members or a loved one. Some of the things that we've done with people across the miles would be like, we created a scavenger hunt that we could all do together, but we did it virtually. So doing things from, a creative stance. Okay, go ahead. So now I'm going to spend some time really teaching you about the importance of the mind-body connection. And so what I'd like to do, you can go to the lemon. What I'd like to do is I would like for you to spend some time visualizing with me. And so pretend that prior to coming here today, I went to the store and I got some really juicy lemons. And I'm going to cut the lemons and they're juicing and oozing with juice. And I'm going to give each of you a piece of my lemon. And what I'd like for you to do is put that lemon in your mouth and bite down on it. And just notice what's happening in your mouth. Okay, go ahead. Go ahead, Lorraine. Next, I'm going to give each of you a piece of this aluminum foil. And I want you to crumple up this aluminum foil and dig your fingers into it and just notice what's happening in your body. Take that aluminum foil and put it into your mouth and bite down on that. And just notice what's happening in your body. Okay, next. Next, if your house is like mine, you come home and there's all these Amazon packages stacked up. Next. And inside, maybe some styrofoam. And so what I want you to do is I want you to break apart that styrofoam, stick your fingers in it, hear it, feel it. And if you want to, take that styrofoam and put it in your mouth. Okay, and last slide. And the last one on Mind Body is this chalkboard. And so if I were in front of you, I want you to pretend that I have very long fingernails. And I'm gonna take them and I'm gonna scratch them down the blackboard. Okay, stop. And what I want you to do is really just to recognize what was happening in your body as I was giving you these photos. And so as I was giving you these photos and you were probably experiencing some physiological reaction to the photos. Now, recognizing that none of these stimuli were actually in front of you, but you were still having that physiological reaction. That is because of our memories and the strong mind-body connection that we have. So I just wanted you to buy into that for a second. Okay, Lorraine, go ahead. So we're going to end today by me teaching you something. So what we're going to do now is I'm going to, if you would like to engage with me, I'm going to time you for 1 minute, and all I want you to do is breathe. So I want you to put your feet firmly on the ground. I want you to get in a comfortable position. And I want you to close your eyes, and I'm going to pick up my cell phone so that I can get to my time. And I would like for you just to breathe. Just breathe as if you're being calm, as if you're focused on your breathing, okay? And I'm going to time you for 1 minute. So count your breaths, okay? Go ahead. Okay, stop breathing. And what I want you to do is just keep that number in your head. So first, I have to mention, as a psychologist, I think it's very appropriate to do experiments on you guys. So hopefully you enjoy this experiment. So I want you to just keep that number in your head of how many breaths you had in 1 minute. But the first thing that I want to ask, and I know I can't interact with you, I wish I could, but I've done this before, is what that 1 minute felt like. So were you in the camp where you were like, this is the longest 1 minute of my life. I can't believe how long this takes. And after this, I have to go to Target and prepare dinner for tonight. Or were you in the camp where you could completely focus on that 1 minute of relaxation? So I will share with you that most people are in the first camp where it's very difficult for them to focus for even 1 minute. And that tells you about us as Americans and how fast our lives are and how common it is for us to have our sympathetic nervous systems revved up. So that picture I showed you before of the stress, to have our sympathetic nervous systems revved up and really doing damage to our bodies. So now I want you to think in your head about how many breaths you took. So if you had more than 15 breaths, or if you were between 10 and 15, or between 6 and 10, or under 6, okay? So I have some bad news just based on the fact that I've done this a number of times throughout my 10-year career. And that's that most of you were probably above 6 breaths per minute, which in my field is hyperventilation. And so I want to share with you that this is something that I can help you change. And so there is some good news associated with that. So if you flip to the next slide, I'm going to teach you a breath called the diaphragmatic breath. So the diaphragm is the large muscle located between the chest and the abdomen. It's that U shape underneath your ribs. This is an area that stimulates relaxation response. It's also loaded with lymph nodes, so that it's important to pull fresh air into there and then pull it out. So most of us breathe from the chest. So we breathe these short, choppy breaths from the chest. And what I like to teach in my practice is how to pull that breath into the diaphragm. And so if we had time today, I would really teach you that diaphragmatic breath. But I can tell you that if you're somebody who does yoga, or you're somebody who sings or plays a wind instrument, or is a runner, you probably know that deep diaphragmatic breath. If not, then it's something important for you to work on just by figuring out where your breath is coming from. So the chest or the diaphragm, and learning to really pull that breath down. Okay, next, this is our final slide today. And so what I want to do today is walk you through an exercise that I guarantee you will decrease that number, that first number you had for 1 minute, and will decrease it to 6 breaths per minute. And the reason I know this is because this is called circular 3 breathing. This is something that I created to help my patients drop their breaths to 6 breaths per minute. And so this is a 9-second breath. And so what you're seeing in front of you is that we inhale steadily for 3 seconds, we hold steadily for 3 seconds, and we exhale steadily for 3 seconds. So a 9-second breath. So what I'm going to do is, if you're willing again, is I'm going to restart the clock for you. I want you to get in your comfortable position again, and I'm going to walk you through the first cadence. And then I want you to continue that cadence yourself, hopefully having a 9-second breath. So therefore under 6 breaths per minute. Okay. All right. So we're ready to begin. In 2, 3, hold, 2, 3, out, 2, 3. Continue. Okay, stop. So if I were with you, I'd want to know your feedback in terms of if this was an easier 1 minute to breathe through, or if your mind was still going askew. What I find is that when I give people something to focus on, this becomes a much easier way to focus. This is also a way for you to do a relaxation or something that's good for you when no one else knows that you're doing this. So I've taught this to my colleagues at the Mellon Center, and I know that they're doing this in tough meetings. I can observe their breath, and I can observe the hold. And really, the hold is a special part of the relaxation process. So that's really where the magic happens, as I call it, because most of the time we breathe in, out, and we don't take time for that hold. And as people get very advanced in this skill, this then turns into a square. So they inhale, they hold, they exhale, and then they hold again before they breathe. And it's really spectacular to see how this impacts their physiological functioning. So we connect people to what's called biofeedback. And so we can read what's happening inside of their bodies physiologically inside their bodies by way of teaching them these techniques. So I hope you enjoyed that today, and I hope you can take that with you and just do something fun. I wouldn't advise doing it driving or anything that could be dangerous, because it really can help to relax you, but take that with you. So I know this was a very brief presentation today, and I covered a lot. And so I wanted to give you a short period of time to ask any questions that you may have, and you know, I'm here to answer those. Yeah, and so I see somebody saying already that circular breathing was much better. So what I teach, we teach a 4-session stress management protocol at Mellon Center, and it starts with a diaphragmatic breath, and that can typically be very difficult for people. I like that breath as the first segment of our stress management, because it really helps people to ground them and to learn how to breathe differently. But this does not tend to be the favorite of our 4-session stress management session. In fact, what I just taught you is, and so thank you very much for that comment. There are a lot of other components to it from a behavioral perspective, as I shared earlier, that we teach, but this is one of the most popular components. And I also love the comment that your mouth was watering when you were looking at that lemon. And I imagine it was probably reacting when you had the aluminum foil or the styrofoam or my nails scraping. And so again, remembering that these were not actual stimuli in front of you. You were not actually feeling them or putting them in your mouth, but this is based on a memory. And so I think that's really important too. There is a question in the chat about mental health help for children with MS and how parents can help deal. And so I think that's a really important question. So most of who, we treat are families. So we treat, we've had patients as young as 3 years old in our offices with their parents, so that they can clearly understand the mental health aspects and the physical health aspects. I think they're both difficult. And so I think finding a good psychologist is really important. So from our perspective at the Mellon Center, we are licensed in Ohio. And so we are able to see people from all over the state of Ohio. However, our societies have given some freedom from the perspective of what states we can see right now, given the global pandemic. And so we've been able to see patients from really almost all throughout the country. So if you're interested, we can certainly help you with that. The blackboard made you cringe. Yeah, I know, right? It's even worse if I'm in there with you and I actually pretend that I'm doing it. The circular breathing slide again. Can you go back to that? Okay, there's the circular breathing slide again. So the goal is that you inhale for 3 seconds, but it's not a quick inhale. It's a slow, steady inhale. So it's a 1, 2, 3 inhale. Then you hold for 3 seconds, and then you exhale for 3 seconds. And so you should be breathing. This should be about a 9-second breath. So the National MS Society, so the question is, who should we ask to find psychologists who can help our family with my MS, our family help? So the National MS Society has a program called the Navigator Program, and in there it lists all mental health providers who are interested in MS care. And so whatever area you're in, you can get directed from the National MS Society's Navigator Program. And the final question that I'll take, because I realize I'm out of time, is, does the breathing help you fall asleep better? Absolutely. We use this for insomnia as well. And so many of our patients have fatigue related to insomnia, and fatigue related to multiple sclerosis, and fatigue related to depression. So fatigue tends to be something that's very difficult for our patients, but there are things that we ask our patients to do. So with fatigue management, it is learning how to take a brief nap during the day when we figure out when that works best. And so when we teach people how to fall asleep very quickly, and these breathing skills are part of that. So thank you. Thank you all so much.
Thank you so much. Namaste, Amy. That was fantastic. And I'm amazed by some of these strategies. They really overlap with what we teach in Yoga Moves classes, the breathing. And yeah, we did a little bit different counts, you know, based on perhaps what, you know, starting with the 3 count, maybe working it up to 4, 5, or 6 counts in between holds. But so similar, and diaphragmatic breath is so powerful.
Yeah, absolutely. Yeah, thank you so much for having me, Mindy.
Thank you so much. We were so excited to have you on our speaker panel. All right, we're going to take a little break. If you have questions for Dr. Amy Sullivan, you can put them in the chat, and we'll make sure that she sees them and answers them for you. And we are going to have our next speaker up in just a minute or two. So take maybe a breath break or a movement break. Take your arms up over your head, maybe do a little twist or a cat-cow in your chair, and get ready because we have an amazing presentation coming up from Dr. Rishika in just a few minutes. So great to see familiar names in the chat, people from Michigan, but also to see so many from outside of Michigan. That's what's so exciting about doing a virtual program. All right, let's introduce our next speaker. I can see her now. So Dr. Prakash, she's the director of the Center for Cognitive and Behavioral Imaging at Ohio State University. She is associate professor in the Department of Psychology. She's a licensed clinical psychologist who's been doing research on lifestyle intervention in people with MS for at least 15 years. I was so excited when I read your bio. She's the director of the Clinical Neuroscience Lab, where she works with PhD students, undergraduate students, and postdoctoral associates to better understand how physical activity training and mindfulness meditation helps improve cognition, reduce depression and anxiety, and impact brain plasticity. In her research is funded by the National MS Society and the National Institute of Health. She's a member of the Psychosocial Wellness Group at the National MS Society, and frequently presents her research on topics of psychosocial wellness to various public audiences. She received the Rising Star designation given by the Association for Psychological Science in 2013, and the Springer Early Career Achievement and Research on Adult Development and Aging by American Psychological Association in 2016. Her presentation today is Mindfulness Training Benefits, Cognitive and Emotional Health in MS. I was so excited to see your description because we do so much of this in our Yoga Moves classes, really emphasizing mindfulness. And so really interested to hear what you have to say today. Thank you so much for being with us.
Absolutely. Thank you for having me here. Hello, everyone. It really is such a pleasure and honor to be here and present some of the work that we have been doing almost for the last decade and a half on mindfulness meditation and how it improves cognitive and emotional health in individuals with MS. I know you all have been sitting for a long time as well, so feel free to stand up, move around as you hear this presentation. I'm planning on doing about 15 minutes of presentation and then about a 10-minute mindfulness meditation practice. So I hope you all would engage with me with that practice. So I think we can go ahead and get my slides started. And I know in the chat feature, several of you are wondering how you can zoom in on the speaker. So there is usually a toggle button that allows you to make either the speaker much bigger or the slides much bigger. So feel free to play around with that. You can also pin a speaker so that you're just looking at the person who's giving the talk. We've been doing a lot of these webinars, so I know that the frustrations that are associated with it. But I also say every webinar that you engage in or every time frustration shows up, that's the perfect opportunity to take a mindful pause. It's okay if things don't work out, or if it's totally okay if your internet crashes. I remember I was giving this talk and I had 300 people on a webinar and my computer just shut down. I was talking and in the midst of it, it just crashed. And it gave me the perfect opportunity to practice what I preach at all times. So just take a deep pause, take a deep breath, just like Dr. Sullivan taught us, and then come back to it. So today what I'm going to be talking to you all about is mindfulness meditation and cognitive augmentation. It seems like these are the wrong slides. Is this the one that you have, Mindy?
Lorraine?
Yes, I apologize. It is. That was
Okay.
but
Can I share my screen?
absolutely.
Okay.
Yep. You should have that button down at the bottom. So just go right ahead, click on that, and my apologies to you.
Oh no, that's totally fine. Like I said, this is just the perfect time for us to take a mindful pause.
Do you see the green button on the bottom of your
yes.
screen? Okay, I'm going to mute and let you take over.
Okay, it says host as disabled participant screen sharing.
Oh.
So can you enable that for me, please?
I do. You should have that now.
Yep.
Thank you.
Mm-hmm. Sorry about that, everyone. Like I said, technology is usually not our friend. All right. Can you all see that?
Yep, I see it.
Okay, perfect. So we are here to talk about mindfulness training and how it benefits cognitive and emotional health in multiple sclerosis. And I like to start with this little quote from Pema Chodron. It really is this opportunity to take a moment and pause on this. Is you are the sky, everything else is just the weather. There's just so much that is happening in our lives in this moment, especially right with the pandemic that's happening all over the country and all sorts of divisiveness that engulfs our country right now. But just noticing that all of these things are just like the weather, and just like the weather, things change. You know, we're right now in the midst of transition, moving from summer to fall, and just recognizing that if we're having bad moments or bad days, they too will change. And just like our slides weren't working right now, and we're getting them to work in this moment. And so much of what we experience as humans is really part and parcel of being human and just living this life. And underneath all of that, we can be this calm sky. So when we think about mindfulness meditation, right, it's a word that's very popularly used right now. Everyone is talking about mindfulness. I know mindfulness was on the cover of Time magazine. Mindfulness was, we have in Ohio, a congressman, Congressman Tim Ryan, who wrote a book called Mindful Nation. We all know mindfulness could really be used at the Capitol Hill. But I know that most of you are from Michigan, so don't hate on me, but I'm from Buckeye Land, and everything that happens in Buckeye Land has to be related to football. So I had been doing research on mindfulness for quite some time, and my dean called me to ask me about my research only when Seattle Seahawks coach Pete Carroll endorsed mindfulness for his football players. So yep, so now we're talking about mindfulness with the dean and everyone. So I thought what I would do is just start with the definition of mindfulness. What do I even mean by this construct? So defining mindfulness, this is the definition that's given by Jon Kabat-Zinn. He's considered to be the founding person responsible for taking a lot of the mindfulness work that has been done in Buddhist traditions and bringing it to the United States in a much more secular and scientific way. So he defines mindfulness as paying attention in a particular way. And that way is purposeful. So you're doing so intentionally, and you're attending to the present moment in a non-judgmental fashion. And I'll, with this exercise that I will be doing, I will be presenting to you what I really mean by this. But it's really this idea that we're inviting our patients and our clients to attend to what shows up in the present moment. And now a lot of you would say, well, the present moment isn't particularly pleasant. It's not something that I want to be focusing on. And we teach a lot of work, or we teach a lot around attitudinal foundations of mindfulness. So doing so in a non-judgmental way. Here's another definition. Mindfulness is an innate human capacity to deliberately pay full attention to where we are, to our actual experiences, and to learn from it. And again, embedded within this definition is this idea is that we are being invited to deliberately, so purposefully paying attention to what shows up for us in this moment and to learn from it, because we have this capacity to learn from our own experiences. And here's a third one. So mindfulness is an open attentiveness to whatever arises in this moment. If it's a strong sensation, showing up for that sensation. If it's a strong thought or an emotion, showing up for that. And what does it mean to show up for those things? So mindfulness-based stress reduction is an effective and evidence-based program that was developed in the United States by Jon Kabat-Zinn at the University of Massachusetts Medical Center in 1978. This entire construct of mindfulness really has been popularized through this mindfulness-based stress reduction program. And it's a 2-month program that we teach our patients here in the clinic, and we meet once a week for about 2.5 hours each, and we engage in these practices. And this program really exists now all over the world. It's been offered in hospitals and clinics. It's being offered in school settings to help young kids and elementary school kids and middle school kids deal with anxiety issues. And it's been being offered in senior citizen centers. Many of the corporations now, so Google has a mindfulness CEO on their board. And then there's tons of research on this topic, and several books have been written, and of course, lots of media covering on this as well. And the practice that we teach in mindfulness-based stress reduction program, it's really this mind-body meditative practice that can quiet the mind and really enhance focus. It can release physical and emotional distress and increase insight and well-being. Now, this discipline really revolves around a particular way of paying attention and how we relate to our mind, to our body, and the experiences in one's life. throughout all of this work, the one thing that I always emphasize to my patients is that it is highly experiential. So I can teach you all there is to teach about and show about mindfulness, but it really requires engagement on their part. And I think, you know, one thing to remember is that when you start paying attention this way, it really affords us a conscious choice to be much more awake in our lives. Now, as I said, there's a lot of slang around, reference around being mindful, but it is far richer than what we all know. It really is about training consciousness, discovering that the awareness that we have is so much vaster than our thoughts are thinking, and accessing this awareness as opposed to getting attached to it. And at lots of levels, it's extremely empowering because we're not being pulled by our emotions or a thought that we had and we're off mind wandering, but it really allows us to make a conscious choice in terms of what we want to do in this moment. And here are the three really important components in this definition of mindfulness that I have been sharing with you, right? It's about paying attention, but you are doing so intentionally. So you're paying attention to the present moment in an intentional way, but with an attitude that is open, kind, and discerning. And these three components of mindfulness really ends up being the cyclical process between the attitudinal foundations, between paying attention, and then having the intention to do so. And I think, as I mentioned just a few moments ago, the attitudinal foundations really are the soil in which we cultivate all of these practices. It really is, and attending to these attitudinal foundations is extremely critical. And so here are the attitudinal foundations that we teach our clients in mindfulness-based stress reduction programs. These are non-judgment, acceptance, trust, letting go, non-striving, patience, beginner's mind, trust, gratitude, generosity. And I could give a whole lecture on each of these attitudinal foundations. And I think the only thing that I would want to mention at this point is that these attitudinal foundations, right, we engage in the opposite of this all the time. And in fact, what I try and really emphasize is that I understand how hard it would be to engage in all of these attitudinal qualities at all times. But we live a much imbalanced life. The balance is almost always tilted towards the opposite of these things. So we're constantly judging, we're in denial, we are impatient, we hold on ever so tightly. And the idea is, can we just start to balance the beam? Anytime the opposite of this attitudinal foundation comes up, can we just notice what is it that we do and how hard do we make things for us? And in fact, in our mindfulness-based stress reduction program, every week we invite our participants to basically pick one of these attitudinal foundations first thing in the morning, and they'll take a sticky note and just put it on their computer and say, today I'm going to work with trust. And it's trust shows up in lots of different ways, right? When you're engaging in exercises, and especially aerobic exercises or any kind of yoga movements as well, you need to be trusting your body. You don't want to be pushing it in the direction where it doesn't necessarily want to go. Or if there are certain emotions that are showing up, so trusting those emotions as well. So this is kind of just to give you a broad overview of the definition of what it means to be mindful, as well as what are some of the different components of mindfulness meditation practices that we teach in our clinic and also engage in our research studies. So as Mindy had mentioned, I do a lot of research in this area of mindfulness meditation. My lab has been funded by the National Multiple Sclerosis Society, as well as the National Institute on Aging. And we are really looking at how mindfulness meditation can be used as a tool, excuse me, tool to improve cognitive functioning in individuals with MS and also improve symptoms of depression and anxiety. But with older adults, we have a very large study that's ongoing right now with 150 older adults, and seeing as we get older, our cognitive functioning declines and our brain plasticity goes down as well. So can we use mindfulness meditation to improve our cognitive functioning? But today, what I'm going to be talking to you a lot about is this CERT-MS trial, which we called the Cognitive and Emotion Regulation Training in Multiple Sclerosis. And the primary aim of this study really was to try and see how mindfulness training can impact what's called emotion dysregulation within this population. And I would be, and I'll just in just a minute explain what emotion dysregulation is. So here is the trial. So this was the aim of the study. The primary aim was we did a 4-week intervention where we combined, where we examined whether mindfulness training would help improve cognitive and emotional health when you compare participants to both an active control group and a passive control group. And I'll talk about that in just a minute. So we had 60 people go through this study, and 20 of these people were randomized to the mindfulness group. The other 20 did the cognitive training program, right? Like lots of people talk about cognitive training at all times. And then the third group did the waitlist control, was basically did not do anything. It was our waitlist control participants. And what we were really interested on to see was if mindfulness meditation would help improve emotion dysregulation and then cognitive functioning. And I'll explain those in just a minute. So as Dr. Sullivan was talking about, right, symptoms of depression and anxiety are much more prevalent in individuals with MS. I know I frequently give this talk to MS neurologists, and in fact, there are some studies that suggest that about 50% of individuals with MS would at some point experience symptoms of depression. And that's a really high number. And a lot of you who are present in this moment might realize that, you know, symptoms of depression and anxiety tend to go hand in hand. A lot of people, when they experience one set of symptoms, also experience another set of symptoms. So one thing that researchers are really interested in understanding is that can we identify common factors or common mechanisms that basically target both symptoms of depression and anxiety? So if through our lifestyle interventions, we can then improve these transdiagnostic factors that underlie lots of different experiences, then people could actually get better, not just on depression, but also anxiety. So what we do in our studies is we look at this emotion dysregulation in individuals with MS. And here's a simple definition. So how do we define emotion dysregulation? It's a pattern of emotional experience and our expression that interferes with appropriate goal-directed behavior and therefore disrupts and compromises adaptive life outcomes. And so basically, any strong emotional reaction that you're having that is not context appropriate, right? Lots of emotions are very context appropriate. A lot of us are grieving at the state of affairs that we find ourselves in, and that's an appropriate response. But we also can help people deal with some of those responses. Or if you hear bad news about your prognosis and get extremely upset about it and get very depressed and can't get out of bed. Or if you have to give a talk, and I always tell this to my students, you have to give a talk, and you know, some level of anxiety is actually adaptive, but if it gets so paralyzing that you get up in front of your audience and you just cannot say a word, and that is what we mean by emotion dysregulation. So it tends to underlie lots of different factors. And when you look at individuals with MS and emotion dysregulation, so we know both in the data that Dr. Sullivan presented, but also in a lot of the work that we have done, is that people with MS tend to experience higher levels of symptoms of depression and anxiety. And we did a study where we matched a large group of individuals with MS to what we call community participants. So they were matched in terms of age, sex, and education levels. And we still found that people with MS experience a high level of depression and anxiety. We also found that emotion dysregulation, you can give questionnaires to people, and that was really high in individuals with MS compared to community controls. And what was interesting was that emotion dysregulation was associated both, as we expected, with symptoms of depression and anxiety, which makes it a good target factor for our trials. So to kind of wrap up the results, and of course I wouldn't be presenting to you if we didn't find significant results. And what we found is that participants, so these are our green participants right here, mindfulness participants, showed a significant reduction in emotion dysregulation from pre-training to post-training. So your green line over here is people who did mindfulness training. And then your blue line here is people who did the cognitive training. So these are your brain training exercises. And the waitlist group is in red, and these are the people who didn't do anything. And so what you see is that individuals with MS who did mindfulness showed a very significant reduction in emotion dysregulation. So this is a pilot study, and so it's really exciting to see a significant reduction in emotion dysregulation. But here is the surprising finding, is that we also collected measures of cognition, and this is the symbol digit modalities test. It's very similar to the PASAT task. I know a lot of you are very familiar with this, but it's a measure of processing speed. How fast can you do things? And it's considered right now, PASAT used to be considered the gold standard way of measuring cognition in individuals with MS, but it really is the oral symbol digit modalities test in the literature that is now considered the gold standard way of assessing cognition. And we had expected that both the mindfulness group, but also the cognitive training group, will show an increase in performance on this, on cognitive measures. But as you see, it was only people in the mindfulness group that really got better in terms of their cognitive functioning. And now lots of people ask, you know, why would that be the case? Why would mindfulness really help with cognitive functioning? And we haven't done this work in individuals with MS, but a lot of our aging work seems to suggest that mindfulness really helps reduce what we call mind wandering. I know none of you right now are engaging in mind wandering, right? The talk is so exciting and engaging. You aren't thinking about what you're gonna do right after this is over, or you aren't thinking about what you had for breakfast earlier this morning. But the truth is that mind wandering is a very common experience that we have as humans. And it's really and it actually serves a really good purpose. I always say I get my best research ideas when my mind is wandering. But mind wandering also allows us to not focus on what it is, what's in front of us right now. And one way that mindfulness can help improve cognition and just our focus is by reducing mind wandering. So like I said, this is a pilot study, and we're hoping to do a much larger trial. In fact, one of our future works really includes doing an online mindfulness-based intervention where much of it is self-paced, but it's validated in individuals with MS. So what I will do is I'm gonna skip over the next few slides and then just basically thank my team for helping doing a lot of this work. You know, these clinical trials where you are collecting data on a large number of people and collecting brain imaging data, and then also collecting cognitive and emotional measures happens with a village. And I am very thankful to be working with a very phenomenal set of PhD students, undergraduate students, as well as postdoctoral associates in doing this research. Our collaborators on this project are absolutely essential. Jackie Nicholas at Ohio Health has been one of my collaborators for quite some time and helps support the MS work that we do. And of course, the funding agencies, National MS Society, as well as the National Institute on Aging. One of the things that we did that I would like to let you all know is that when this pandemic started, as a clinical psychologist, something that kept coming to mind was, how could I help people with the resources that we have developed? So we launched our YouTube channel. So everything that we have been putting together in the last 15 years in terms of mindfulness practices, as well as defining mindfulness, what does it mean to have these attitudinal foundations? All of these videos are now posted on this YouTube channel. In the spring semester, I also did an 8-week seminar series on just introducing people to mindfulness and having them engage in the practice. I'm hoping to do that sometime again in the fall semester. But if any of you are interested in just getting access, completely free access to mindfulness practices, you're welcome to go to this YouTube channel. And someone is mentioning that they're not visible, but I think I can go ahead and type that in the chat link in a minute. So that's kind of my talk, and I want to take the next 5 to 7 minutes to have you all engage in a mindfulness practice. You all up for it?
Absolutely, we're up for it.
All right, I got one yes, I'll take that. I'm going to stop the share now. All right, so we all have been sitting or standing for a while now. So let's go ahead and get some movement in. So I invite you to kind of close your eyes, but just make sure you're in a place where you're safe and secure. And what we're going to do is we're going to take a deep inhalation, roll our shoulders up, 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 and feel the tension, and exhale. Let's do this 2 more times at your own pace. Inhaling the shoulders up, up, and exhale. And one last time. And just with that last breath, kind of settling in. And you know, you all have been here for a couple of hours and are together with all of us for the next 2 hours or so. But for now, let's not even think about that far ahead. What we're going to do right now is to just learn what it means to attend to the present moment. We've been talking about that for the last 15 minutes, as mindfulness is all about being in the present moment. But what is your experience in this very moment? And what do I even mean by that question? What are you aware of in this moment? So we'll do a little internal exploration. So imagine as if you're noticing is like a flashlight that we will be shining on different aspects of your experience. And you can follow along as best as you can. So bringing your attention to your body sitting here, or even standing if you find yourselves right there. Feel the weight of your body. Notice what it's like to bring attention to your body sitting here. Offering your body a simple and kind attention. What's it like to bring attention to your body? What do you notice? Not looking for anything in particular, just noticing whatever is there to notice. Do you notice any sensations that are present in your body? Heaviness, lightness, perhaps some warmth, or maybe even some coolness. Maybe you notice some tension or tightness, or maybe just some ease. Just noticing. And now bring that light of awareness to breathing. How do you know that you're breathing? Where do you feel the breath moving in your body? What's it like to just watch and notice your body sitting here? What sensations of breath do you notice? Simply noticing. Simply paying attention with the purpose of paying attention in this present moment. All sorts of distractions arise. All these things we all have to do. Things that happened in the past. No big deal. Don't judge yourself for that. Just like you would pick up a puppy in training, with the same kind of gentleness and compassion, pick up your attention and move it to any awareness of feelings or emotions that you may have. So as you scan your experience in this moment, are you aware of any particular feelings of, say, emotional ease or distress? Any anxiety at all? Maybe some of you are feeling happiness and others sadness. Just notice with a kind and compassionate attention. What's it like to take time to notice how you're feeling? And lastly, let's bring our attention to our thoughts, to our thinking mind. As you observe your mind, what do you notice? Streams of thinking, thoughts coming and going, thoughts about what has come before or what is yet to come. Just notice. And in the final moments of this practice, just bringing your attention back to your whole body breathing here, in this moment. Lots of commitments, lots of plans, lots of worrying. But here you are, taking time for yourself. So committing to staying present and being with what shows up for us. And I'll ring a bell, which will signify the end of this practice. So just really allowing yourself to nourish in these final moments of present centered awareness. Thank you for your time. And I realize that I'm a little bit over time, so I would be happy to take questions in the chat, also post links to my YouTube channel. Just know that you are highly courageous and brave for engaging in this work with me. And I'll send you more details and answer questions on chat. Thank you.
You are amazing. And please look in the chat, ask Dr. Prakash questions and she'll answer them. Know that mindfulness is a practice. We're not perfect. It's a lifetime practice. And thank you so much. I've been waiting to hear your presentation for quite a while. Very exciting. All right, we are on to Trent McIntyre, and he presented at our in-person event last year, and people were so excited. They're like, bring Trent back, bring Trent back. So here he is. He's so much fun. For more than 20 years, Trent's been helping those that experience movement challenges and neurological disorders to gain back their mobility, a story he knows well. Born with a mild form of cerebral palsy, Trent was able to repattern his own movement to eliminate the pain and stiffness he experienced daily. His ability to repair his own body lifted the ceiling, allowing Trent to actively participate in his love of sports and moving on to becoming a professional dancer. Today, Trent teaches his proprietary techniques and strategies worldwide to help improve brain performance. He's best known in the movement world as the problem solver. Thank you so much. Biohacking Your Potential with Trent McIntyre.
Awesome. Thank you, Mindy. It's so great to be here. And I'm going to ask Mindy if you'll kind of be on standby as my interactive go-to, because I know we have lots of people on the call and I want to make sure that I get a little feedback on what I'm doing so that will help the group feel and experience this as we go along. So
Absolutely.
Instead of showing a video, what I really want to do is, first of all, welcome everybody to an experience that I hope helps you better understand how you can biohack your potential. And to make that really easy, you don't have to be a brain scientist to tap into this. It's really simple. And I want you to feel how it's possible, even virtually. So in the last 10 years of my research and work, the most interesting aspect for me has been playing with and discovering and inventing ways to get the brain to listen and respond quickly and to get results that last a long time, to lower stress, to improve movement quality, to regulate emotions. And one of the easiest ways to do that is to simply learn how to do eye tracking. And eye tracking has been around for a long time, but it's not very fun usually. And that's actually what led me to inventing the Brain Speed Ball, which is something I'm not able to play catch with you here today, but I will reference this later to give you an idea of how this can be done with a partner or just on your own against a wall. But today I want you to feel how it's possible to notice how much the eyes play a role in helping your body move. So if you're experiencing any kind of stiffness or pain or stress, you can actually tap into a simple exercise to help overcome that. So Mindy, you'll be my body. I'm talking to everybody, but just so I have somebody to kind of respond. So what I want everybody to do is just find a place where you can sit comfortably and you're off of the back of your chair. And so you can just feel your sit bones on the chair. You can feel your feet on the ground. And I want you to just to take a simple rotation of your spine as much as you can without strain to your right. So you're just going to rotate your spine to the right as far as you feel like you're able to do. And then bring yourself back to center. You with me, Mindy? All right, we're going to turn again.
I'm with you.
Beautiful, beautiful. We're going to turn to the right again, just so you can kind of take check of what that range of motion feels like and what it might bring up for you in terms of tightness, stress, etc. Now, do it again, but this time I want you to first look to your right. So you take your eyeballs to your right first. Now take that rotation again and see if you go any further. Just notice that and bring it back to center. Try it again. Take your eyes to your right and then rotate as far as you can without strain. Now to show you the difference, I want you to start with your eyes now to the left. So first, look with your eyes to the left. Now, move with me to your right and feel kind of how yucky that is. Right? Try that again. Eyes to the left and turn your spine to the right. And come back. Now, let's do it again with the eyes going to the right. Eyes to the right. You with me? Turn to the right and go as far as you can. And notice how much farther you can go when you're looking in the direction that you're moving. Yeah, it's pretty amazing. Let's do the left side. So we'll first look to the left. Take a deep breath with me. You're gonna exhale, rotate, keep looking to the left, go as far as you can. Bring it back to center. Take another breath with me. Look to the left. Turn your body to the left. Remember, no strain, just your range. Looking as far as you can with your eyeballs. Come back to center. Now the little torture part, just so you can feel the difference. Look to your right first, and then rotate to your left. And your brain's like, no, no thank you. That doesn't feel good at all.
No way.
One more time, look left and turn left just to make sure you give your brain a little pat on the back that it's able to move. Good, come back to center. Yeah, it is torture to look the opposite direction, you're right. So let's take a pause here for a second. So when it comes to your ability to move and have lower stress and regulate, your eyes play such a huge role, because if you don't feel safe moving, it's surrounded and based in how well your eyes can see. Not acuity, like is it a clear image that you're reading on a piece of paper, but physically, can the eyes move in that direction? So as you're looking at maintaining and improving range of motion in your body and feeling balanced and centered, your eye strength and range of motion plays a really key role. And so you can actually do eye exercises just like that to improve how big a range and how big of a map your eyes can see. So let's do a couple more spine movements so you can really feel it in two other pathways here. So we're gonna start by looking up. So still sitting off of your chair, look up, take a breath in, and then as you breathe out, just kind of arch your spine as far as you feel comfortable. Don't strain it, no pain, come back to center. Do one more, just so you can check in, see what yours feels like. Go as far as you go in your body and bring it back to center. All right, here comes the other part. Look down, and then we're gonna extend. And what kind of signals does that bring up for you? Do you feel the stress show up? It's yuck. Yeah, someone put in yuck. Yeah.
Torture.
So it's torture. So when you're moving on in your day and your eyes have issues or struggles and looking in different directions, that stress gets added. Dizzy, yeah, be careful. that stress, you compound that stress without even realizing that it's coming from your eyes, right? So if you have a pen or a pencil handy, you can use like the tip of it, just something that you can see clearly. And if you already have a brain speed ball, you could use a ball as well. But we're just going to spell the alphabet to give you an idea of how easy this could be. So whether you have a ball or you have a marker or a pen, great, Minnie's got her ball. You're going to hold it out. I'm going to turn sideways so you can see a little better. You're going to hold it out in front of you comfortably. You're going to keep your head as quiet as possible. And we're going to start by just working on the letter A. So just we're going to repeat A 3 times, keeping your head center and straight, looking at your pen or your ball. And you're just going to draw the letter A, big capital A, cross it in the middle. Do that again. Start at the bottom, go to the apex, come back down, and cross it in the middle, right? One more time. Up to the apex, bring it back down, cross it in the middle. Now, for a lot of people, drawing an A is not too challenging. The letters stay pretty centered in your eye frame, so you're not being challenged by looking out really far. So what you can do is actually going through the alphabet, and I'm gonna skip right to H, because H is a really good one. So I'll show you with the marker this time. So if you draw the H, if you hold the marker in front of your face, and you draw the H as far as you can, keeping in your eyesight, draw the side of the H over there, come back to the center, move with me through the middle to the left side, draw the other side of the H there, bring it back to center. Let's do that one more time. So from center, take it to the right, watch it go up to the corner, watch it come back down to the bottom, back to the middle, and center, center, and to the left one more time, up to the corner, down to the bottom, back to the middle, and then center, center. Take a break there. So you might notice with the H that you have more challenge because you're taking your eyes in a greater range of motion. And the idea here is that you can spell your name, you could do the alphabet, you could do numbers, but the point here is that you focus on a range of motion that feels challenging, but doesn't create strain and doesn't overload you with dizziness or stress or harsh emotions, which can happen. So this is important because if you go so far to create strain, then your brain's going to dump the information. It's going to be like, no, that doesn't feel good. That causes fear. That might startle you. It might not feel supportive. And so it's not going to be something that's going to help you lower the stress. So, you know, coming out of that great conversation about mindfulness, you can bring that into this situation so that as you're tracking whatever letter you're tracking, let's say you track it 5 times, you notice where it becomes challenging. So like for me, this upper right corner is my hardest spot. So I might not go as high on this side as I might go on this side, on my left side. And that's okay. But the important thing is that you honor where that range of motion is and you bring your mindfulness and awareness to what that range should be for you. So often, you know, we're looking to other people to like answer the question, am I doing this right? And in this case, there's not a wrong way to do this, except to say that if you make it too hard, it's not going to feel good and feel productive, right? So let's take this idea of tracking the pen, or if you have the ball, you can use the ball, and you're going to take that into a rotation of your spine again. So if you hold it out in front of you so you can spot it, now you have your whole body involved, not just your spine. And you're going to watch the ball as you turn your head behind you. And then you come back to center. And what's great about this exercise is that it also brings in your vestibular system because you're moving your head. As simple as this, 4 or 5 times, and then changing sides. Do the other side. Tracking, make it really simple. Don't get too stressed or worried about it. Just see the letter or number or see your pen cap and track it back and forth. Let's take a big arc. Let's go up in the air. Let's go up in the air and then behind you, right? So you can play with the range of motion for the eyes, and you might notice that as it goes up, it's like, oh, that's kind of harder up there. And it gets a little easier as it comes down. For me, that's the case, right? Take a break there. Again, there's not a wrong way to do your eye tracking, only to say that if you make it too easy, that's not going to help you very much. If you make it too hard, it's definitely not going to help you very much. But we don't have a regular practice in our society for exercising our eyes. You know, there's some really brilliant vision therapists that if you have a condition, you have a special need, you can go get help, but it's in a clinic. It doesn't feel fun. And to me, from my research, making it fun helps people want to do it. It gives you adaptability. It gives, you know, even the most severe situation, somebody some hope that they can find a solution. And I saw somebody just put in the chat, there's a help with vertigo. It does. With somebody with vertigo, what I would say is I'm going to down level the exercise as much as possible. So I might not start with this big range of motion. I might start with just a small range of motion. One of my clients that I'm seeing right now on a regular basis virtually is she'd recently suffered a stroke, and dizziness and vertigo is a real issue for her because of some damage, but this applies to anybody in any condition. She's not doing humongous range of motion. For her, the challenge is just a small range, and that feels effortful and fatiguing. So again, listen to your body, start small, and you can work yourself bigger. And that's really important. It's what I've discovered is that since we know with all of our sensory systems, the brain listens to the eyes It prioritizes the information coming from the eyes. We can tap into improvement by using the eyes to send information to the brain. And you don't have to be a neuroscientist. You don't have to know one. I know all of you do, but you don't have to have that background to exercise your eyes. And so often in our body, when we're working out or exercising, we're looking at strengthening the muscles to move your joints and move your bones around and stretch and be mobile. It's the same thing with your eyes. So all these exercises that I've showed you, it's to make your eyes stronger, more flexible, and better coordinated, which gives you better information from your environment as you go on with your day and do your daily activities to the brain, so you can feel safe and you can feel grounded and feel more capable. And that's really what it's about, is feeling more capable. So I did provide a PDF that has some more information. Also, there is a really wonderful 21-day challenge on the website, and I think we've provided a link for you. If not, we can throw it in the chat. It's brainspeedclub.com, and there's a little tab for the 21-day challenge, and it's a free training. So you get some videos and you get a download with the calendar, with a new way to play with the BrainSpeed ball every day for 21 days. If you don't have a ball and you can't get one, you could make one. You could use something else to track. The point of this is that you make eye tracking a habit. So with whatever resources you have, make eye tracking a habit. Make talking to your brain through the way it wants to hear a priority. It wants to hear through the eyes. It's going to listen to the eyes, whether they're strong or not. So why not make them strong? Why not make them, take them to your best advantage in this situation? Good. Mindy, do you have any questions or anything that you'd like me to speak on before we wrap up?
There's one question in chat, if you can answer that.
Sure.
In the chat. And all your information is in the exhibit hall. So you can go to the exhibit hall, you receive the link for that, and check out pretty much everything Trent was talking about and find out about the BrainSpeed ball and the challenge that he's running.
Yeah, fantastic. And also on the website, at the bottom, there's a little, I think it's green, it's a chat box. If you throw in questions, that chat box, it actually comes right to me. So as you're looking at it and watching videos or have questions, you can throw it in that chat box if you're on the website, and you'll get me right away as well. So you'll have the bat phone to get some answers for you.
Thank you so much,
Awesome.
Trent.
Thank you, Mindy. Thank you, everyone. Enjoy the rest of your time. Fantastic.
Okay, thank you. Have a wonderful day. Thank you so much. We are on Dr. Voci. Dr. James Voci is going to introduce Dr. Rani. And I just want you to know how special this man and physician is. He's been the chair of Yoga Moves MS for like 6 years now. He didn't know what he was getting himself into when he started, but he's been a major, important part of our growth, our leadership, and our planning. Thank you so much, Dr. Voci, for being here today.
Thank you, Mindy. And thank you, everyone, for being here. And Mindy, thank you for putting together a great collection of speakers. It's been wonderful so far. And we're going to now have 3 very special neurologists coming up for the next half. And these are both people who have really advanced the care of neurology, both locally as well as nationally and internationally. Our first is Dr. Rani Aburashad, who has served as the Chief of Neurology and the Director of the Multiple Sclerosis Center at the Memorial Institute for Neurosciences and MS. He holds a clinical faculty position at Central Michigan University and serves as the Medical Director for Specialty Care at Memorial Hospital. His center is designated as an MS or comprehensive MS center by the National MS Society, which is a very coveted achievement. He has lectured on various aspects of multiple sclerosis, both nationally and internationally. He's published numerous articles and abstracts surrounding MS therapeutics, as well as on progressive multifocal leukoencephalopathy and different autoimmune disorders of the central nervous system. His research team is currently focused on the role of blood biomarkers as measures of predictive change in multiple sclerosis, something we've been desperate to have. He was the first in the US to use neurofilament light chain measurements, amongst other markers, in real-world MS patients. He served as principal investigator for numerous phase 1, 2, and 3 clinical trials in multiple sclerosis. He's received numerous awards, including the Richard Alper Memorial Award, the Michigan Medical School Grant Award, and our very own Yoga Moves MS Leadership Award in 2018. His presentation today will be neurofilament light chain and the role of biosignatures in multiple sclerosis. And Rani, thank you for being here. Go ahead.
Thank you so much for that introduction, Dr. Voci. So I first want to say thank you to Dr. Voci. Those of you who don't know, he's being a little bit humble in terms of, well, he didn't really say much, but Mindy kind of downplayed him. So Dr. Voci has been—
No way.
Yeah, no, you didn't downplay him, but I do want people to understand. So Dr. Voci is an incredibly busy person and someone who takes a lot of time out of his life to do this. And he's passionate about it, and it you know, emanates in everything that he does with it. So I want to give him a direct thank you from me for everything he does. And in addition to that, I do want to thank Mindy and the Yoga Moves MS team for putting this on, because it's pretty remarkable when you look at where people are from. I went through all your names and kind of, you know, I've been reading, you know, the chat box throughout the day, and people are from all over the place, which is just incredible when you think about it, because these virtual things have become tedious, I think, and this is just an outstanding group. So thank you for that. Mindy, should I give a talk?
Yeah, you should give a talk.
All right, let's give a talk.
You're really good at it too.
Well, we'll see what we can do. So if you can get my slides up, that'd be great. All right, so thank you, everyone. Welcome. My name is Randy. I know many of you, and I see many of my patients' names in this little participant box. So to all of you, I would call you all out individually and say hello, but I can't. But hello to you all. So I'm excited to speak to you guys about something that I'm very passionate about, and it's gonna probably resonate, I think, with the group in terms of what we're trying to do. We've been working on this very diligently since May of last year. COVID slowed us a little bit, but we've had some recent advancements that have been really, really fun to kind of watch, and have kept me up many nights. But at the same time, it's just, you know, you're kind of trudging step by step closer. So I'm going to talk about neurofilament light, as well as kind of the newer protocols that we're using, looking at biosignatures directly. So with that, I'll begin. Do I advance, or do you, Mindy? I do. Perfect. All right. So what is neurofilament light? So one of the questions that I've always asked in terms of MS as I've gone through this, and, and one of the challenges that I've always struggled with has been really, you know, is what I'm doing correct? When you think about MS, you know, I think as a patient, sometimes you kind of have an inclination that your doctor knows exactly what they're doing. And this may come as a shock to many of you, but many docs don't know entirely what they're doing. They know a lot of the science behind it, but in terms of, you know, this is entirely the right decision, I think it takes a lot of intellectual honesty to know that we don't always have all the answers. And so when you understand that fully, you kind of can begin the process of trying to answer questions within yourself and within your practice and within a certain disease state. And so for the last really 10 years, that's been an interest of mine, because I always found it interesting. I'd go to a meeting and there'd be 15, you know, world experts, and no one agreed on anything. And I said, well, that just tells you we don't know. And so with that, me and my team have really focused entirely on trying to get that objective answer, trying to provide information to the greater world in terms of this is the right step for a patient. And so that led us to looking at blood biomarkers. So let's start with what that means. So a blood biomarker essentially is an additive feature when we're trying to determine what a patient's multiple sclerosis is, not from a diagnostic standpoint. So I already diagnose you based on MRI and based on your symptoms. So let's say I have your diagnosis. A blood biomarker is a way for me to see the unseen, a way for me to foreshadow your disorder and to assess kind of where you may be in 10 years, where you may be in 15 years, and then to hopefully apply a change now before any of that damage occurs that can positively impact or bring down that level of disability. So the idea here is, you know, I'll use cancer as an example because I think it fits really well. You know, if I were to test your blood for, you know, a certain marker, and I were able to say, oh, you have this very tiny cancer, but it's not going to do anything. It's not going to worsen. It's not going to spread. It's going to remain benign the whole time. that approach for you as a patient mentally is very different than me saying you have this cancer and I have no idea if it's going to be horrible or if it's going to remain benign forever. Because now I've changed your life entirely. I've altered your entire psychological mindset. And for the rest of your life, you will wake up day by day wondering if today is the day that the cancer gets severe or spreads. And so my goal is to answer those questions first. And then once I'm able to answer it, then be able to say, all right, you have this cancer based on this blood test. And it's a cancer that concerns me a little bit. So I'm going to zap it now before it ever gets worse, right? So in the situation like that, I'm ahead of the cancer. I'm basically preemptively treating. So when you look at multiple sclerosis in this particular room, out of the couple hundred people that are here, there are people who live entirely normal lives for the most part, maybe occasional bad days. And there are people who are in wheelchairs and have severe spasticity, severe pain, urinary changes. So you have this breadth of patient care. And in that patient who's doing entirely well, who has no symptoms and no disability, versus that patient who ended up in a wheelchair, there's everything in between. And so looking at blood is much more detail oriented than looking at someone's MRI. So the MRI is very useful to predict your case. However, it has a ton of limitations, and Dr. Voci and the other clinicians on this webcast can, attest to this. So we've focused entirely on a marker that we believe gives us a lot of information very early in the disease, and that marker is something called neurofilament light. And if you look at this this picture that we developed last year. This kind of begins the process of understanding it. So when you look at a nerve cell specifically, all of you are familiar. Can you see my arrow, Mindy, when I move it? No?
I do not see an arrow moving.
Okay. There might be a way. Hold on. I think I have a way. I may not, but nonetheless. All right, I'm not going to waste too much time. So if you look at the purple in this, the purple sausages that you see here represent myelin. And every one of you is very familiar with myelin. You've been to a million talks. And myelin is kind of the insulating coat.
We see it now.
Okay. Well, that's someone else, but whoever's doing a good job, you're right where I want you. So myelin serves as the insulating coat of your neurons, and every one of you knows that. And underneath that myelin is the actual axon, which transmits information. So when you think about this in the brain, there's billions of these neurons, and you have electrical signals that begin here, travel down the length of this axon, and then synapse here at the end, and then they pass that information to another network that goes travel down, and basically it's like handing off a ball, right? It's handing that electrical signal. It's called an action potential, and it's just transmitting that information second by second, millisecond by millisecond, billions of times a day, right? So when I lift my right arm, all I'm doing is transmitting that information from the left frontal cortex and just rapidly bringing it into the arm. So that's all. It's this massive connection network that really is the most remarkable thing you can think of. Well, that axon is really the wire that transmits that information, and the myelin allows that wire to move information much more quickly, right? So that myelin speeds up transmission. So in MS, all of you are familiar with something called demyelination, where you lose that outer covering and hence get slowed signals. Well, there's a lot more to it than just that, because it's not just a demyelinating disease. So you can have the actual covering, the myelin, get damaged alone in isolation. You can have the axon itself get damaged. And you can have really the whole structure be transected in some cases when you talk about black holes where you have severe axonal loss. Well, underneath that, in the internal part of the wire, there is this scaffold, and this scaffold is made up of 5 proteins, okay? Those proteins, 3 of them, the most prominent parts, are neurofilaments. So neurofilament heavy, based on its molecular weight, neurofilament medium, and then neurofilament light. Neurofilament light is the most predominant of these proteins, and there's a couple other peptides in there as well. These proteins, what they do is they essentially hold up the axon. They make that wire a little bit bulkier, and they increase really its surface area to allow it to transmit information across broader ranges or broader breadths of areas. So if you have a wire that's very small, it goes, from point A to point B. Well, if you can expand that wire and stretch it as much as you can, it now expands its territory. The ability for it to kind of transmit information becomes more powerful, and it becomes more efficient, right? So you want efficiency in the brain. You want quick information. Well, when you end up with damage to the brain in any way, where you have neuronal damage, and say it can be a concussion where someone gets punched in the face and the head goes through this shear injury, or a multiple sclerosis plaque where T and B cells are attacking the brain, you end up with damage and you end up with leakage of these proteins. And you can kind of see that in the bottom of this diagram with the arrow here. These proteins start to leak into the spinal fluid, which is the blue part of this picture here. And eventually they leak into the brain, okay? So neurofilaments, and I want you to focus on neurofilament light, leaks after damage, or when there's any ongoing damage, into the spinal fluid and then later into the blood. If we can go to the next slide, that'd be great. When you think of multiple sclerosis, we have really dual processes that are occurring. So let's hang on to that first image that we had in our head of that neurofilament leaking into the spinal fluid. Well, that can occur in a variety of ways, right? So in multiple sclerosis very early, this is a very inflammatory disease. So you see a ton of B and T cells rushing into the brain, attacking myelin, just chewing it piece by piece, right? And they're getting some of the axon too. So you're getting the wire and you're getting the covering, just chewing and chewing and chewing. And the neurofilaments are just leaking out, right? Well, as you get older, this disease changes. And many of you in this room have had MRIs repeated over and over again. And your doctor says, oh, the MRI looks stable. The MRI looks stable. And you're like, but I'm not doing well, or I'm getting worse, or something's not right. And the doctor kind of shrugs his shoulder or her shoulder and says, you know, well, based on the available data, you know, you're doing okay. And you know, we'll do a little something, see if we can get you better. Well, that's fine because that's the best that we have right now. However, there's also an underlying element to this where when you think of that picture that we had before with the myelin being chewed, don't think of MS only as B and T cells attacking myelin. Also understand that once you develop this disease, once you have those inflammatory cells occur, some of those cells remain trapped underneath and they slowly leak into the actual cord. Okay, into the actual, into the actual wire. So underneath the axon. And they slowly degrade kind of internally that scaffold. So that picture, that mindset that I told you about the axon where it's, you know, a very thin wire has very thin information, one-to-one. However, if you can broaden that wire, it gives it more density and more surface area. Well, everything can look perfectly great in your multiple sclerosis from an MRI standpoint. However, underneath here, you might be having, you know, slow chewing, microglial chewing of that protein. And that little area starts to shrink a little bit. And it's shrinking slowly over time as you get older. And eventually what happens is you're getting slowly worse, right? Because those neurofilaments are being chewed up and the axon in terms becomes less efficient. So when you think of MS, I want you to picture two things. One is the direct, obvious inflammation on the exterior of the nerve cell. And then two is the more concerning part, which is that slow axonal loss over time, that slow atrophy. If we can go to the next slide, that'd be great. So we can see a great example of this here. So on the left side of this picture, you see an MRI with kind of the classic multiple sclerosis T2 hyperintense lesions, right? And these are located in classic areas of the brain. So if you see those two pons, God, I wish I had a little hand thing. Can you move the hand, whoever's moving the hand for me? Bring it over here, left, left, left. Okay, so go to the white area on the first picture. Okay, so those two white areas, that little butterfly you see there, that little butterfly is actually where the spinal fluid is, okay? So those are the ventricles, and they look black on the further right image because it's just a different sequence. We're just using a different filter, right? Nonetheless, that's where the fluid in the brain lives, and it kind of circulates downwards into the spinal canal. Well, around that area is kind of a classic territory for multiple sclerosis lesions. And you see these classic ovoid white lesions that are very obvious in the picture on the left. And that's just inflammation, demyelination, destruction of tissue around there. And the second picture shows you another area that's commonly affected called the perivenular area. So in this one, the black part there you see underneath that white lesion, that little black thing is the same ventricle that I showed you on the first picture. That's where the fluid is, but above it is brain. And so you're getting demyelination there. Well, if you go to the right picture completely, let's go to the right picture entirely. You don't see many white lesions on this, right? I think everyone can agree that the picture on the left looks very different than the picture on the right. However, what you do notice is the pons those pons, those ventricles start to enlarge, okay? That enlargement is actually atrophy. It's shrinkage of the brain. And so this is actually the same patient. And this is an MRI done in 5-year intervals over a 15-year period. So the picture on the left was their brain in the beginning. No, scratch that. Get rid of the picture on the left of the right image. So picture A was at the baseline. Picture B was, and this one is actually 7.5 years later. And then picture C was 7.5 years after that. So 15 years later. And you can see the striking difference in how much atrophy this patient has. So this patient's brain has shrunk significantly in terms of in the last 15 years, but you don't see a ton of white lesions surrounding it, right? So classically, that demyelination is those white, people ask me all the time, how many lesions do I have? And I really don't care, to be honest with you. It doesn't matter to me how many lesions you have. That's not the fight I need to win. I can win that fight. We've gotten very good at, I mean, trust me, it matters. I'm not trying to downgrade it, but I can win that fight. Those lesions tell me if I have good control of the inflammatory component of your disease. The bigger question, the bigger goal for me is, can I stop your brain from shrinking? Because if I can stop it from shrinking, I can potentially stop you from worsening and give your brain a chance to slowly improve over time. So let's go to the next slide. And yes, Lindsay, that's a ton of brain loss. I agree. So to help understand this further, we've developed a model that we call the neurofoundational model. And this is I built this model for patients because, it's something that I think I want patients to understand what we're trying to do in our research, because I think it helps you as a patient if you're part of our research. So let's look at the model of a neuron as a home. Okay. So on the left in panel A, that's a normal home. So what you see here is you see the roof of the house, and that roof represents myelin. You see the house itself, and that represents the axon, right? That represents that wire. And then underneath that house, you see the foundation of the home. So in a normal home, that would be the concrete slab, okay? And so that would be a normal structure of a neuron. If you go to panel B, you see that, let's say you get an MRI on panel B. An MRI on panel B is gonna show me white lesions everywhere because this patient's roof is on fire. There is demyelination occurring, correct? So this patient has an active MS attack. Film A and B, B and T cells are attacking the roof, and they're actually causing this to be on fire. Now on an MRI here, I'm probably gonna call Dr. Voci and say, man, this guy's brain's on fire. We need to put the fire out, right? Well, if you notice on film B, it may look horrible, but when a fire occurs, yes, there is scarring. However, you can repair damaged paint, and you can replace a roof. You can actually improve that. But what you'll notice is there's a little bit of a crack in the foundation in panel B. So yes, there is a little bit of leakage of that concrete, of that neurofilament level. So let's say I draw this patient's blood at the time of this attack. They've got this horrible MRI that looks really bad, but they have very small leakage of neurofilament. The foundation of the home remains intact. And because that foundation remains intact, I know that I can probably stabilize and improve this person, okay? And I will answer your question shortly, Catherine, about the spinal cord. So because this person's concrete slab is intact, I know that we can actually bring this home back to its normal, or at least as close to normal as possible, okay? Now let's look at panel C. This can be another MS patient who has a severe attack that actually transects the entire home. So the roof is damaged, the myelin is chewed up, the axon is damaged significantly, and then the concrete slab is damaged as well. And this person, I draw their blood, their neurofilament level is gonna be incredibly high because there is damage to all three structures, and especially damage to the concrete. That's the part I really wanna hold on to, that I need to preserve as best I can, right? And then the one that bothers me the most is letter D, sorry. So D represents that insidious, slow progression that's occurring in an MS patient. And many of you have this. And so I want you to pay attention to this for a second. The insidious, slow progression occurs because of those trapped cells that I mentioned earlier, right? And I believe they're microglial cells. So those cells, it's like having a flood underneath a house. So I get the MRI and I say the MRI looks stable. However, underneath that MRI, in an area that we can't pick up on the MRI, is this slow flooding, and it's causing neurofilaments to leak into the spinal fluid and into the blood. So I can measure that patient's NFL, and I can actually see an elevation in that level significantly, suggesting that whatever I'm doing isn't enough yet, or I'm not able to get to the crux of their problem. And I'm going to answer two of the questions while I'm on this slide, and then keep going. So one of the questions was about the spinal cord. So how does this apply to the spinal cord lesions that have never gone away? So the first thing I want to tell you, lesions, for the most part, will never go away in the majority of patients, okay? So just because you have chronic lesions is not a reason to panic or worry. Most MS patients will have lesions from 15 years ago they never knew about, and we'll see them forever. So the idea of getting rid of a lesion itself is not a goal that should be in your mind. If it happens, absolutely amazing, we love it, and I do see that on occasion. If that lesion is active, okay? If that lesion is actively inflamed, yes, we want that activity to go away. We will still see the scar, but we want that activity to go away. So pay close attention to this. Every one of you who has MS will have some lesions in the brain and probably in the spinal cord, at least 40% of you in the spinal cord as well, okay? Those lesions are like looking at your MS from 10,000 feet. And it's just giving, it's like looking at the Battle of Gettysburg from above, okay? 10 years later. You can see damaged soil, you can see blood stains. This is a terrible analogy, but it works. You can see the areas where horses have trampled, but the war is not active right now. The war is done, okay? But yes, I can see kind of the playing field and how it looked. Those shouldn't make you panic. If I look down there and I see active war, if I see inflammation from gadolinium, that dye that we put in your vein when we get an MRI, if I see that inflammation, that's a different discussion entirely. My goal is to stop that inflammation, get another MRI, and make sure that all I see is a battlefield and no active war. When it comes to the spinal cord is made up of exactly the same tissue that I discussed in the brain. All of it is neurons. So this what I'm describing to you, this model, fits entirely into any spinal lesion as well. So it represents the same thing. And then somebody asked, how do we stop brain loss? And that was a great question. And I'm going to try to answer that towards the end of this. So let's keep going from there. Next slide, please. Okay, so what have we found? So when we first started neurofilament, and just so many of you understand, this is an entirely new kind of discipline. So this isn't easy. There's no playbook to what we're doing. And it's been a labor of love, a labor of frustration, a labor of amazement, and we continue to kind of grow in it. And now it's gotten to the point where it's getting very exciting, at least to me, and it's fantastic. And I'll end with what that means. So when we first started, we didn't even know what normal levels were, right? So everyone's brain is constantly aging, no matter who we are. We're like cars, right? You never have a new car. Your car is never as new as it is today, right? And your brain is the same way. So as we age, we normally are going to have shrinkage of the brain, and that shrinkage of the brain is going to actually cause leakage of neurofilament. So the first thing we wanted to do was look at what's normal. What is the effect of age on neurofilaments? Because an 18-year-old's brain is going to atrophy or shrink much differently than a 70-year-old's brain. So the first thing we did was we got as much data as we could, and you can see the numbers in the middle there. So really, everything was relatively stable until mid-50, okay? Once you get into the mid-50s, really 52, 53, you start to see a slight elevation in neurofilament, just for normal. So for all of us out there, don't freak out about that, that's normal. But we do see a slight elevation. So it went up to 12 in that population. Once you jump to 60, it jumps up pretty significantly. It jumped up 4 picograms per deciliter. And then once you get to 70, it really makes a jump, and so on and so forth. So we really have 5.5 decades of life where the brain does a pretty good job of self-preservation, okay? And we needed to understand this to apply this to multiple sclerosis, because my goal with this is that when I see patient A in front of me, that I am individually treating that patient entirely. So I'm not speaking in broad strokes of this is kind of what I do with patients. No, what I want to do, what I want to get to is to a point where I say, hey, patient A, here are your numbers. These numbers concern me because of, or these numbers give me reassurance because of, and we're going to apply the following treatment, even if it's risky because we have to, or I don't want to take risk in you because I don't need to at this stage. That is the end goal of what we're trying to do. So go ahead to the next slide, please. So once we establish this age idea, the next step we wanted to know is, does it mean anything? Like, do these numbers mean anything? Because remember, this is like finding a new island, right? When you get on a new island, you see these species out there that you've never seen, and you're trying to describe them. So we have this number, we have this arbitrary number that we're getting off of our machine, and really no one has a good handle on what it means. So the next step was to try to figure out if it actually means something meaningful. So for example, if you have a neurofilament level that is 30 versus 10, does it make a difference in terms of how you look, right? And the answer was a glaring yes. So this actually was a very joyous day for us in the clinic when we had this. When we crunched these numbers, it was really an important day for us because we had some data in retrospective trials on this that suggested it. But to me, this was essential. I needed to know that when we're looking at these markers that we're actually going to be able to see a correlation and a prediction that may matter, because then if I intervene and work this number as aggressively as possible, in theory, it should change kind of how a patient's doing. So what we did to assess that was a couple of things. One was the 9-hole peg test, which I'm sure many of you are familiar with. And if you're in our clinic, we do this on you every time you come in. And this 9-hole peg test is very simple, and it just basically gives us an idea of your dexterity in your hands, right? We want to know how well your hands are moving, how quickly they are, and it gives us an idea of how fast you are. So we have you take these pegs, put them into the 9 pegs, into the 9 holes, and then take them out one by one. And then we time you. And we have data for our patients, we have databases with all your information. So before I see you, I'm looking at 2017, 2018, 2019, 2020. And I'm tracking that. I'm seeing kind of what that number is doing. Is it trending downward? Now, this is important for you to understand. As a patient, you may not notice the subtle change. So if you have a 20% change in your speed, you might not pick up on that in your day-to-day because you're not doing fine motor activity every day. So it doesn't affect your ability to use your phone, doesn't affect your ability to, use a remote control or something. So I can pick up on that slightly earlier. And the neurofilament level that a patient had was very predictive of that, which was a huge thing because it meant something, at least clinically. I believe it means something. So go ahead to the next slide. So we tested that. And then we tested something called the 25-foot time walk, which is something that, again, our patients, you're going to get this every time you come in. And for most of the clinicians on here, they're going to do them on everybody they see. And this is very important because the idea here is how fast are you able to move? In isolation, this means very little to me. So if I were to meet you today, check your 25-foot time walk, I'm not going to really care what it is. Whether it's 3 seconds or 8 seconds, it is what it is. That's just where you are in space, right? However, if it's 8 seconds today, and I see you 6 months later and it's 12 seconds, and I see you 6 months later and it's 13 seconds, right? That is a negative trend in terms of your ambulation. So you're starting to slow down. You're starting to kind of, transiently have this degradation that's occurring in the background that you may not notice again, because who the heck times himself walking, right? Unless you're an athlete who uses an Apple Watch and says, I run 6-minute miles. Most people don't do that on a day-to-day basis. So we wanted to look at 25-foot time walk. We wanted to look at the 9-hole peg test, 2 very objective functional measures. And we wanted to look at neurofilament levels at various points as we measured these patients. And we continue to do this in our population. So our study is 5 years. So we're in year 2 of 5 right now. And we have data that we will submit throughout this. However, clearly the neurofilament levels that we were seeing in our patients were correlating very closely and relatively accurately with the timed walk as well as the 9-hole peg test, especially when we took out age as a factor. So we needed to correct for age, obviously, because if I take an 80-year-old who doesn't have MS, he's going to be slower with his hands than a 20-year-old. So once we protect for age, we then look at 25-foot individually and 9-hole peg individually. So, and both of them showed a direct correlation with neurofilament levels. So go ahead. Next slide, please. And so why does this matter? the last question that we wanted to answer was, all right, so we have these numbers and we want to assess whether the medications themselves can affect these numbers in a meaningful way. So shortly you're going to hear from one of my buddies, Dr. Boster, who's a phenomenal guy and a great lecturer and a fantastic clinician. And Aaron and I are very similar in a lot of ways in terms of how we approach this disease. And I think that's kind of the basis of our friendship started with that. Is for years, we kind of were pounding the table behind the scenes about, I think, some of the conservative approaches that many did. And I understand why people were conservative. However, we've kind of, evolved now. And now you're starting to see the rest of the world understand why we were doing that. And now the data is showing that that's really the way to go. And the question I had was, all right, so I'm using these different drugs and you guys see all these drugs and there's more coming out. I mean, we've got 16 trials right now in our place that are going on for phase 2 or phase 3 stuff. There's so many drugs that are on the horizon. And the question that we wanted to answer was, all right, do the drugs actually make a difference? So when we look at patients who are on drug X, Y, or Z, or in this case, A, B, C, D, E, F, G, and H, does it matter and does it have an effect on the neurofilament level? And the answer was absolutely. And you can see that here in this table. Now, I don't put the names of the medications in here. That is on purpose. I know what they are. And we continue to expand on this database. So as we get through this number and we start to kind of, so one of the things for us that was huge, we had a lot of patients who came to us not on treatment. So you can see 163 cases we had and this is old data. We now have much more than this, but 163 cases, were not on treatment when they came to us. So these are patients who had what we would call chronic multiple sclerosis. And the doctors who they were seeing said, let's just take you off treatment entirely, or let's just, you're going to be fine. The inflammation's gone. Well, their neurofilament levels clearly were significantly higher, even when we correct for age. So there's no question that the treatment has a profound effect on the neurofilament levels. And what I told you earlier about the 9-hole peg test and the 25-foot time walk, it would suggest that if we get that level as low as possible, hopefully it will change and slow down the progression of the walking and of the dexterity issues and of the cognitive issues and so on and so forth. So that was kind of the first chunk of research that we did between May of 2019 and this all continues as we speak, between May of 2019 and now. However, there is another layer to this that I want to introduce to you today as I wrap up here and then take some questions if you have them. So now what we've done is really gone several steps further, and it's been very exciting to see. And we are now in the process of working with some big people in terms of looking at a biosignature. So neurofilament, we know, is a very big component. However, we also hypothesize and believe that there are several other proteins that when you add to the mix, so I draw your blood and I check your neurofilament level and I check protein A, B, and C. For us, it's a quadplex, and we have 2 add-ons too that we're testing now. So it's 6 biomarkers. When you take those 6 biomarkers and you put them into kind of an algorithm, you start to see ratios. And those ratios might be even more predictive in a patient than neurofilament alone. And we believe that wholeheartedly. So that has been really our big focus right now. And we continue to finish protocols in this regard. And we've gotten funding for this, which is exciting. But so the goal here is, can we come up with a biosignature for you as an individual patient based on the best available data? Can we take that biosignature and can we apply it to your case? Can we put you on a treatment or a therapy, the right treatment or therapy very early in the disease or as early as we get you, whether you're 50 or you're 20? And once we do that, can I measure that biosignature again in 3 months and in 6 months and in 9 months to make sure that what I'm doing is actually having the effect that I want on you? And that is the future of MS care. And that is exceedingly exciting. And it's awesome, and we love it, and it's so cool. And we're hopeful that, this is going to be our life's work. I mean, this is kind of our focus, and it's very exciting for us to be, at the forefront of it, and something that we're proud of, but there's so much information that we want. And there's a lot of questions on this, so I'm going to answer some of the questions. Let me see. So do you want me just to pick the questions at large here, Mindy?
Rainey, if we could ask, can we maybe try to answer them on the side? We are running a bit behind.
Okay, sure.
Okay.
So yeah, I can do that. Absolutely.
Awesome. And thank you for a lovely discussion. I hope everyone paid attention. This is really something we have desperately been looking forward to help guide us in helping you get better. So thank you for bringing everyone up to date on NFL. And thank you for all the work you're doing.
My pleasure. Thank you.
All right. So with that, we're going to move on to our second of the clinician speakers. We are very pleased as well to have Dr. Martin Belkin here, who is the medical director of the MS Center at the Michigan Institute for Neurologic Disorders. This is one of the largest private MS centers in the country, and it has certainly left a strong mark in the state of Michigan for their work in MS care. In addition to his extensive experience as the primary and sub-investigator for clinical trials in MS, he is also known nationally as an excellent speaker on the topic of MS. He is actively involved in educating medical students and residents in the field of neurology. He serves as residency program director for Ascension Macomb Oakland Neurology's residency program. He is also a clinical assistant professor at Michigan State University's College of Osteopathic Medicine, as well as Oakland University William Beaumont School of Medicine. And he was our 2019 Yoga Moves MS Leadership Award recipient. Martin's presentation will be on recent advances in MS therapeutics and clinical research. And Dr. Belkin, thank you for being here.
Thank you. I think the slide should pop up. Yeah, certainly want to thank Mindy and Dr. Bocci for inviting me to speak today and really giving me the privilege of talking about recent advances in MS therapies, clinical research. Our center has always been at the forefront of research started by my mentor, Dr. Howard Rossman, and we've been able to continue it and really take it to the next level. So we're going to talk, there's a lot of information. I have about 15 minutes to talk, and it's about 2 hours worth of information, so I apologize. I'm going to talk quickly. I'm happy to try to answer questions after the fact so we can keep the program moving or even at a later time. So we'll just get going. So next slide. So real quick to kind of talk about the classification of MS. Many of you, I'm sure, have seen this slide in some iteration, but just real briefly, it's classified. There's clinically isolated syndrome. That's where patients may have one clinical event in an MRI with at least 2 lesions that are typical of MS lesions, but they haven't had any other clinical episodes. Majority of patients, though, about 85%, have relapsing remitting multiple sclerosis. That's characterized by relapses with complete or incomplete improvement, followed at some point at a later time with another relapse, and so on and so forth. However, those patients who are untreated or certainly undertreated, often eventually or majority somewhere down the road will enter what's called secondary progressive MS. And that's characterized by slow, steady progression and may still be active and characterized as active SPMS, where they still have relapses, although continue to have progression in between, or non-active SPMS, where it's generally just slow, steady progression, which may plateau at a certain point, but otherwise continues to progress. And then about 10% of patients are what are considered primary progressive MS, which is essentially from symptom onset or disease onset. There's generally a slow, steady progression. So next slide. Again, another slide that many of you have seen in some way, shape, or form, but I just wanted to highlight a couple things. So one, we know there's this subclinical or preclinical activity where if you were to get an MRI on someone who ultimately was diagnosed with MS, you would actually see typical MS lesions until they cross a threshold and have that first clinical event. And then they go on to that relapse or remitting type phase in most cases. I mean, again, in those who are undertreated or not treated at all, eventually develop a more progressive phase. And you see that purple line, they develop that more, that ongoing clinical disability. And as they develop more clinical disability, we know that there's less inflammation going on. And we believe it's more of a neurodegenerative disorder at that point. And that's shown by that orange line. And then that light blue line that you see declining is talking about brain volume and brain atrophy. And as you've heard just a bit ago, we know that patients with MS brains atrophy at a greater rate than normal controls. And that actually, there's more evidence that that starts at the time of diagnosis. And so we need treatments, we need therapies that are going to slow brain atrophy, if not bring it back to physiologic levels, the same as normal controls. And so, so that's going to be critical, and we're going to talk more about that as we go forward. So next slide. So here's a slide talking a few different factors. So one is neurological reserve. And what we do know is your brain has the ability to compensate. So when damage is done to your brain, and such as the lesions that we see with MS, your brain can compensate. So you don't actually have symptoms, you don't develop disability progression until you lose that reserve. And once you lose that reserve, and you lose that reserve essentially from atrophy of the brain, you cross that threshold of losing enough neurons, enough brain cells, enough brain atrophy, where now you start having more symptoms. Now you start having progression of your disease and disability progression. We've always thought of MS as a white matter disease, white matter being those areas of the brain filled with myelin, again, talking about the covering of the neurons, the myelin. But what we've learned in recent years is that it's largely also a gray matter disease. And gray matter is really tough to identify. You can't see gray matter damage on routine imaging. It's hard to assess. And we know that that actually begins at the time of diagnosis. And so what we've learned is that patients need to be treated early, and they need to be treated aggressively. So we can preserve white matter, but even as important, preserve that gray matter. And then healthy, oh no, not ready, back. And then we know that lifestyle is definitely, no question, plays a role. And we'll talk a little bit about that. So diet and nutrition, diet and inflammation, so much we need to learn, but we know there's a correlation between diet and inflammation, and having a healthy lifestyle, exercise, movement, mindfulness are gonna be extremely important in how someone does with MS. And then comorbidities. We know that patients with high blood pressure, diabetes, high cholesterol, and if that leads to vascular disease, those patients don't do as well. That'll factor into brain reserve and reducing your neurological reserve. So controlling all those comorbidities is going to be critical for a patient with MS. Next slide. So that brings us to recently approved therapies. And you know, it's amazing what's happened in the last 15 years in terms of MS therapeutics. Basically in 2006, natalizumab was approved, which is our 5th therapy, and it was a tremendous addition and still one of our most effective therapies. But now we have over 20 therapies. And so we can really tailor treatment to an individual patient, to their lifestyle, to their risk tolerance. So many factors go into that decision making. And so I'm going to highlight the most recently approved therapies. I'm going to talk really quickly. There's so much data in each one, and I'm just going to highlight a little bit of data on each therapy. And then we'll get into some emerging therapies. So we're going to talk about Mavenclad or cladribine, then 2 medications that are in a class called S1P receptor modulators, Mayzent or Siponimod, Zeposia, which is ozanimod. We're going to talk about Vumerity, which is diroximel fumarate, and then Kesimpta, which is the latest approved treatment, which just was approved recently, called ofatumumab. Next slide. So the first therapy we're going to talk about is Mavenclad or cladribine. This is really unique because it's a non-continuous therapy. It's called a short course oral therapy. And to take a step back. So as you know, as I think you've just heard, MS is an autoimmune disorder. Your immune cells, these inflammatory cells called lymphocytes, B and T cells, are programmed they have memory to attack myelin. So they get into the area of the brain and spinal cord and they cause inflammation. They attack myelin and lead to the damage in terms of MS. And so Mavenclad is an oral therapy, but it's unique in the sense that it's weight-based dosing. So patients get 4 to 5 days of therapy. A month later, another 4 to 5 days. They're done for a year. And then year 2, they get another 4 or 5 days. And a month later, again, finish off another 4 to 5 days of therapy. And then they're done and they're just monitored. And the theory is they're reducing those B and T cells. And again, those B and T cells have memory. And it's thought that possibly by knocking down those B and T cells, when they repopulate, they no longer have memory to attack myelin. And that may play into the beneficial effect of this therapy. And so really unique drug, really beneficial, highly effective. And some of the clinical trial data I just want to highlight. So this was a trial done compared to placebo. And so one of the primary endpoints was annualized relapse rate. So the chance of having a relapse, it was reduced 58% compared to placebo. So dramatic reduction in relapse rate compared to placebo. The MRI, just want to highlight one of the MRI factors, so T1 GAD enhancing lesions. So the T1 lesions, those are the lesions that take up contrast. So that tells us that's active inflammation. So 86% fewer active inflammatory lesions on MRI compared to placebo. Then they also showed, again, what's going to be critically important is disability progression. So 33% reduction in the risk of 3-month confirmed disability progression. So clearly slows disability progression. So highly effective therapy, really unique in terms of dosing and mechanism of action. Next, we're going to talk about S1P receptor modulators. So this is a group, we have 3 of them, but we're going to focus on the 2 most recently approved. The first will be Mayzent, but what they do is those being T cells, those lymphocytes, they sequester them, they keep them in the lymph nodes so they can't get out. So if they can't get out, they're not going to be able to enter the brain and spinal cord to cause that inflammation. And so Mayzent is a once-a-day oral medication, very well tolerated medication. And this again was compared to placebo and 55% relapse rate reduction. So dramatic reduction in relapse rate, again, compared to placebo, showed benefit in terms of slowing disability progression, 26%. And I wanted to bring up this, they did look at SDMT score. SDMT is called a symbol digit modality test. And it's a test that can be done in the office setting. It's a 90-second test. You're matching numbers to symbols. And it's been well validated in terms of looking at cognition and particularly cognitive processing speed. And so what Mayzent was able to show is they can slow the worsening of that SDMT score. And so obviously that's telling us potentially slowing any potential cognitive dysfunction or cognitive slowing, which obviously is going to be critical for any patient with MS. Next is the other S1P receptor modulator, Zeposia or ozanimod. Again, want to highlight a little bit of data. Again, a lot more data for all of these therapies that we could talk about another time with a lot more information, but this was a trial compared to Avonex. So keeping in mind, this was not compared to placebo. This was compared to a medication, interferon beta 1A, a once a week injectable medication that many patients have been on for years and have done very well with. So it was compared to patients on that therapy. And you see, compared to patients on Avonex, a 48% reduction in relapse rate in a trial, the first trial, which was a 1-year trial, and 38% in the Radiance trial, which was a 2-year trial. So significant reduction in relapses compared to patients who were on an effective therapy. I also want to highlight, they have very good data, although it's considered exploratory and nominal endpoints in terms of brain atrophy. And we were talking about really the ultimate goal of all our therapies is really to preserve the brain. We want to preserve the brain. That's going to ultimately allow patients to do well long-term. And so they showed fantastic data in terms of slowing or significantly slowing brain atrophy. And here is just looking at the whole brain volume loss. And you see significant reduction in both trials of reducing brain volume loss. But they did also subdivide it into what's called cortical atrophy and thalamic atrophy. And really thalamic atrophy is going to be quite important because that's been really well correlated to disability progression and cognition. And they showed very good data, significant data in terms of slowing that thalamic and overall brain atrophy. And we're going to get a little bit more into brain atrophy as coming up in later slides. Next. So the other recently approved, or another recently approved therapy is Vumerity or diroximel fumarate. Now, diroximel fumarate is the same active metabolite. The active metabolite is called monomethyl fumarate. It's a medication that many of you may be on and familiar with called Tecfidera, which is dimethyl fumarate. So very effective drug. We've now had it for several years. A lot of patients have been started on this medication and maintained and done outstanding. One limitation of this medication, though, is for many people, they have side effects, primarily GI symptoms, and that can be a limiting factor and really prevent them from being able to successfully stay on this medication. So this actually was able to reduce the number of, days with GI symptoms by 46%. So much better tolerated medication than Tecfidera, and really so patients who would be appropriate patients for Tecfidera or dimethyl fumarate or are on it and having GI symptoms, really a better option to go on just from a tolerability standpoint, give patients a much greater likelihood of being successful in this therapy. Now, in terms of data, this is data derived from the initial trials with Tecfidera, dimethyl fumarate, 49% relative risk reduction in the proportion of patients that relapsed over 2 years. So again, dramatic reduction in patients who have relapses over a period of 2 years. And then finally, I want to talk about the most recently approved medication, Kesimpta or ofatumumab. This is an anti-CD20 B-cell depleting therapy. So we talked about part of the pathology in MS are B cells and T cells. And B cells and T cells, they work together to interact to then go and attack myelin and cause the inflammation and demyelination that occurs. And so by depleting these B cells, we know that we can have a dramatic effect in terms of reducing inflammation, reducing disability progression, reducing MRI activity in patients with MS. So a highly effective therapy, aggressive therapy. And so this is the latest addition in ofatumumab. It's actually a subcutaneous injection. There's a loading phase, but then it's ultimately once a month. It's administered by patients at home. So that can certainly be a benefit for some patients. But if you want to look at the data, we'll highlight it real quickly. So this was actually compared to teriflunomide. Teriflunomide is an oral medication, very widely used. Again, a lot of patients do very well on it. But compared to teriflunomide, that relapse rate reduction you can see in 2 different trials, 51 and 59% reduction sequentially or respectively. So really positive effect on that inflammation. And so really great addition in terms of treating MS patients. And then it showed a 34% reduction in confirmed disability progression versus teriflunomide. So again, slowing disability progression. But I think really what we'd want to highlight is the effect on MRI. And if you see those GAD-enhancing lesions, those lesions that take up contrast, tell us there's active inflammation going on, almost suppression of those GAD-enhancing lesions for patients on teriflunomide, patients on ofatumumab, compared to patients who are on an effective therapy that's effective for many people. Next slide. So that brings us to emerging therapy. So again, we have over 20 approved therapies, great for patients with MS, but we still ultimately need more options and really to be able to tailor treatment to patients really on an individual basis. And where research is going in terms of disease-modifying therapies, there's going to be several trials starting, and our clinic has been privileged to be involved in these trials as well, are called BTK inhibitors or Bruton's tyrosine kinase inhibitors, and they're involved again in B cell development. And so they may reduce inflammation, they may reduce neuronal cell damage. And I think what's exciting or potentially exciting for this class of therapies is it may be effective for both relapsing as well as progressive forms of MS. Obviously, we have still a great need to help patients with progressive forms of MS. And so this class of therapies, we're hopeful will show benefit in progressive forms of MS. The trials, again, we still have a ways to go, but we're excited to be part of these trials and helping patients get access to this medication. Next. So we talked about disease-modifying therapies, but I think possibly right now we have so many great therapies. So the unmet need is how do we repair myelin? How do we repair damage that was previously done? And so there is work, there is research ongoing in terms of repair therapies. And again, our clinic has been privileged to be part of pretty much all of these trials. And the question is really, one is ultimately, do they work? And if they cause or lead to remyelination, does that lead to functional improvement? And so obviously we don't have data yet, but these phase 2 trials are completing. And the first is something that affects what's called RGMA protein, or repulsive guidance molecular membrane A protein, more than you need to know. But basically what this does is this protein will inhibit cell repair. And so by using what's called a monoclonal antibody, it'll target this protein, potentially allowing for remyelination or repair. And so really exciting, and we're excited to get some data and hopefully move on to phase 3 trials and see if ultimately this can be approved to help patients with MS. And next slide. A second one, which we're also involved with, is a phase 2 trial that's finishing called Anti-LINGO. And this is another it's an IV formulation, IV therapy that has a potential to allow the cells that make myelin, called oligodendrocytes, allow them to turn on, allow them to actually produce myelin once again. And again, very exciting that we have this potential agent. Again, we have to find out, will it truly do what we hope it does? Who is it helpful for? Will it lead to functional improvement? But the fact that we have these agents and the science is there behind it, that they can actually lead to myelination, I think is extremely exciting. Next slide. And then there's future trial agents. There's been some really early research on something called gold nanocrystals. And these gold nanocrystals, what they can do is they work on the cellular metabolism. And so they can improve the metabolism of those cells that make myelin, called oligodendrocytes. And by doing so, they can allow it to actually turn on again and make myelin. in order to do that, it takes so much cellular energy. And so the cells just don't have that capability. So these gold nanocrystals can improve metabolism and allow myelin repair. Again, this is really early, but again, just showing that the research is heading in that direction. And the second one you see here called an S1P4 receptor antagonist. This is actually a trial that we'll be involved with as well. That's going to be an oral, potential for oral repair. So instead of an IV therapy, this will be an oral therapy. And the S1P4 receptor, by blocking that receptor, again, you can allow those oligodendrocytes, those cells that make myelin, to turn on and again, start myelin repair. And then we talked a lot about, and you've heard earlier today, about other factors, not just medication. So diet and inflammation. We know that diet and inflammation, there's a correlation there. Foods that you eat can cause inflammation. What we don't really have, we don't have large studies telling us which diet is really the best for MS, or is there a specific diet or specific food? You know, I think most of us believe that processed foods, sugar, certainly contribute to inflammation, but we need more research. So we know that diet is gonna be, is a big factor in inflammation, and we just need more research along that front. And then the gut microbiome, so a hot topic, not just for MS, a lot of neurodegenerative disorders. And we know that there's a difference in the makeup of the gut bacteria in patients with MS. And I'm going to show a slide of a poster that was just presented at an international meeting, ECTRIMS. But it's different in MS patients than healthy controls. And so can you correct that gut microbiome? And will that have a positive effect in the long run? And then antioxidant agents, alpha lipoic acid. It has a potential to reduce brain atrophy. And I'm not putting this on there at telling people to go start alpha lipoic acid, but showing that there's research in things other than just standard pharmaceuticals that can be used in conjunction with treatments we have to really help patients. So it's not going to be a single agent for everyone. It's almost going to be a multi, almost in a sense, disciplinary approach from different avenues to try to help patients with MS in the future. And then we need emerging MRI technologies. You've heard about brain atrophy, and really ultimately the goal is to preserve the brain. But how do we measure brain atrophy? And standard MRI really doesn't do it. We have MRI techniques, software that are used to look at brain atrophy, but there's so many variables that really affect the usefulness of it clinically. So you're really not able to use those to make clinical decisions. And so you need MRI technology advancements to really look at brain atrophy. And I'll show a slide of a poster also that was presented that our clinic was involved with, looking at artificial intelligence, looking at the thalamic atrophy specifically. So we'll just finish up these next couple slides. So this next slide, again, was talking about the gut microbiome. Basically, real simple. It was a poster presented showing that the microbial diversity in MS patients is different than healthy control. So there's a different makeup of the bacteria in the gut of MS patients. And ultimately, will that lead to therapeutics that can alter the gut microbiome that will have an effect on inflammation and neurodegeneration? And last slide. And this was, again, the poster looking at thalamic atrophy measurements using just routine clinical MRIs. So nothing fancy, just the MRIs you get every day, but you can, with artificial intelligence, this was developed by Dr. Zavadinoff in Buffalo. And so we were privileged to be asked to be part of this group to use regular MRI and his software that he's developing for artificial intelligence to actually measure brain atrophy in thalamus. And he showed that this may be truly feasible. And again, hoping this eventually becomes validated and somewhere down the road part of routine imaging studies, so we can really follow MS patients to a much more to a much finer degree and really tailor treatment more specifically and follow how they're doing. So and then I think just a summary slide. So really fast, we covered a lot in a very short period of time, but we talked about the recently approved therapies, which is just great additions. It just allows us to really tailor treatment and really make sure patients are treated early and aggressively. We talked about emerging therapies. We talked about the potential ability to repair myelin. We talked about, some agents that may offer some neuroprotection. Nutrition is going to be a key in patients with MS, controlling other risk factors, diabetes, vascular disease, hypertension, not smoking, and then altering the gut microbiome. And then ultimately the need for these more advanced imaging techniques so we can really look at brain atrophy and make sure patients are being treated appropriately and effectively. And so that's it. I don't know if we have time to take questions, but I'm happy to try to answer them on the side, or certainly they can get them to me at a later time.
Yeah, Dr. Buck, I think if you can maybe answer some of the questions in the chat box, that would be good, because we are running a bit behind.
Yes. So right now, I see a question, can someone take multiple therapies at one time? And the answer is right now, no. Some of that certainly has to do with insurance, but we also don't have data. But there's some thought that combination therapy may ultimately be part of the future to attack MS from different mechanisms at different times. And so, you know, we would need data to support doing that, but there's some theories behind there that potentially medications that work quite differently and some that may have more of a protective mechanism may be helpful to use in conjunction with each other. So that may be the future, but certainly not right now. That's the only question I see.
Okay, well, Dr. Belkin, thank you. If any other questions come up, you can maybe answer them on the chat box. That would be helpful. Thank you for a lovely update. And thank you for your time. We really appreciate it. This is, again, a very nice collection of physicians we have speaking today, and Mindy, again, a great job of getting everyone together for this event. So we do have 2 more discussions. We're going to do a little bit of a switch on the schedule. Our next speaker will be Dr. Aaron Boster, who Dr. Rania Burashad had mentioned. We are very honored and pleased to have him as our 3rd physician speaking today. Dr. Boster is a board-certified neurologist who specializes in MS care and other CNS inflammatory disorders. He decided to become an MS doctor at the young age of 12 when he had the situation of watching his Uncle Mark suffer from the disease in an era before treatment was available. Dr. Boster grew up in Columbus, Ohio, attended Oberlin College for undergraduate work, and then went to his medical degree at the University of Cincinnati College of Medicine. He then completed an internship and residency in neurology at University of Michigan, hence his ties to Michigan, and then following that, a 2-year fellowship in clinical neuroimmunology at Wayne State University with Dr. Kahn and Dr. Lissack. Since then, he has been intimately involved in the care of patients impacted by MS. He has been a principal investigator in numerous clinical trials, trained multiple MS doctors and nurse practitioners. He has published extensively in medical journals. He is known both nationally and internationally. He lectures to both patients and providers worldwide with a mission to educate, energize, and empower people impacted by MS. He lives in Columbus, Ohio with his wife, Chrissy, his son, Maxwell, and his daughter, Betty May. We are honored and pleased to have you here, Dr. Boster, and the exciting title of this topic is How to Make MS Boring. So thank you for your presence today. Thanks.
Howdy. Thank you so much for having me. Can everyone hear me okay? It's always crazy talking into a computer and hoping that the world can receive you. I really think that post-COVID, we'll probably start face-to-face conversations saying, can you hear and see me okay? My name's Aaron Boster, and thank you for learning about MS with me today. As mentioned, I decided to become an MS doctor when I was 12, not because my Uncle Mark had MS. He had had MS since my earliest memory. But I remember coming into the kitchen at my grandmother's home. My mother and my grandmother were sitting there holding hands. Their heads were bowed and they were crying. Why was my mom crying? Because she couldn't get a hold of my uncle's doctor. He was having a problem and she was scared and alone. And this predates therapies. It predates the interwebs. It predates the involvement of organizations like this one. And I told my mother at age 12 that I would learn to do it better, that I would learn to do a better job of caring for people impacted by MS. So I was this weirdo in high school that said, I'm going to be a multiple sclerosis doctor. I've had a very, very directed course. And it's truly become my mission to help people impacted by MS live their very best lives despite having this condition. Now, I am asked very frequently, hey, Dr. B, when will there be a cure? When are we going to cure this disease? Humbly, I share with you that I don't think that in my lifetime we will find a cure for multiple sclerosis. But let's be very honest with each other. In medicine, we don't cure things. We don't cure diabetes, we treat it. We don't cure things, we can treat them. And in fact, diabetes is a great example. Diabetes, which is another autoimmune disease, was a death sentence just 3 generations ago. People who had diabetes, 20 years into the disease, would go into renal failure and they would die. Nowadays, you don't even know that your girlfriend has diabetes unless you happen to order chocolate cake after lunch and she pulls out her little insulin pen and you say, honey, what are you doing? She says, oh, I'm taking my insulin. Now, I'm not suggesting for a moment that it's easy to have diabetes, but when you do it right, when you are fastidious, when you are an involved member of your care team, you can make having diabetes very boring. And I am thrilled to share with you a not secret. In 2020, today, we can make MS boring. In fact, I'm going to spend the next half an hour of our lives talking to you about how we can make MS boring in the now. There's 3 ways to make MS boring, and let's walk through all 3 of them. The first way that we make MS boring is we identify and treat MS attacks. An attack, a flare, an exacerbation, a relapse, it's all the same thing. It's when something bad happens to you, you can't see, God forbid, or your hand is clumsy, or your foot feels like it's in ice, and after a day or 2, it won't go away and you can't blow it off and you have to fess up to your wife, honey, I can't see. We can treat attacks. And if you have a new neurological symptom, I want you to holler at your doctor. So if you have a new neurological symptom lasting longer than a day, I implore you to holler at your provider helping you with your MS care. Now, on the other end of the phone, they should demand to see you, right? We don't do fake medicine where we call in a prescription of steroids over the phone without looking into what's going on. No, we need to see you. Now, in the modern COVID era, that may be on telemedicine, so be it. But we need to take a careful history. We need to see what we can on exam, and we need to check a urinalysis to make sure that you don't have an occult urinary tract infection. If you have a UTI, we're going to give you antibiotics and make it better. If you're not having an infection, we're going to give you big dog steroids and quell that inflammation and hasten the recovery. I also, as a pro tip, will suggest to you that 6 weeks after your attack, you need to be seen in follow-up. That's right, you need to come back into clinic, or in the modern COVID era, you need to jump back on telemedicine. And we need to make sure of 2 things. Number 1, that you've gotten better. Because if you haven't gotten better yet, we're not done yet. And there is more that we can do to help you in your road to recovery, regaining that neurological function. Number 2, we have to take a moment to consider what disease-modifying therapy you were just on. Because if you're taking a birth control and you get knocked up, it didn't work. And if you're taking a medicine to prevent attacks and you had one, it didn't work. And we need to make sure that we call that out and we discuss, do we stay on this medicine or do we need to upgrade? The first way that we make MS boring is we identify attacks or pseudo attacks and we crush them. We get you back into play. I kind of consider my job as an MS neurologist like being a kid's hockey coach, and you are the star on the ice. And you go out there and you spend some minutes and you come back off and I dust you off and I give you some hot chocolate and I throw you back out on the ice, because I don't want MS to make decisions for you. I want you to make decisions for you, and I don't want an attack to get in your way. So the first way that we make MS boring is we treat MS attacks. Did you know that if you pour Guinness Stout into a coffee mug, it looks like you're drinking coffee? Now, the second way that we make MS boring is we treat symptoms. Symptoms are things that suck. Symptoms are things that you don't like. And in the setting of multiple sclerosis, you can have an attack where you don't fully recover. And let me use an example of an attack where your left leg feels like it's on fire. It burns. And we give you steroids and it gets 90% better. And you are left with a residual symptom. You're left with a chronic symptom where your leg, particularly when you're overtired or when you're really hot, starts to feel like it's burning again. And it can make it really uncomfortable to sit for a long time or to walk. You have accrued a chronic symptom. Now, if I slow your MS down, if I make your MS not progress and you're miserable in the process, I have not done my best job. And I'm going to tell you a not secret. I don't do a bad job. In order for me to go home and look at my children and say, today, your dad did a good job, I have to do 2 things. I have to slow your disease down, and I have to elevate your quality of life. I have to help you be the most awesome version of you possible despite having MS. And the number 1 way that I do that is by treating chronic symptoms. In fact, as I work with patients over years and now decades, we spend increasingly more time optimizing them and treating chronic symptoms. And when I think about symptoms, I really think about the invisible nature of multiple sclerosis. So much of MS pathology is invisible. And honey, you look so good. You don't look sick. Well, you don't look ill-informed, but you are. And so much of what goes on in multiple sclerosis is invisible. The leading cause of loss of work in MS is not because you can't walk. It's because you can't think. It's because of cognitive fatigue and pathologic fatigue where you fall asleep at your desk. And that brings me to my first constellation of invisible symptoms, the up there's. The up there's are a triad of 3 symptoms that are extremely common in MS. The most common symptom in all of multiple sclerosis is fatigue. And I watch my patient's face melt when they say in the clinic room, I'm tired, and the spouse says, yeah, me too. Because unfortunately, the spouse is not picking up what they're putting down. The best way that I have been able to explain fatigue from an MS standpoint is as follows. On Monday, I want you to go to work and I want you to work your butt off. And then I want you to come home and have dinner with your family. And then I want you to watch TV. And then when everyone goes to bed, I don't want you to go to sleep. I want you to jump onto my YouTube channel and I want you to watch YouTube videos all night long. And in the morning, shower and go to work. Tuesday morning, go to work and work your butt off. Now, Tuesday night, I want you to come home and I want you to have dinner with your family. And then afterwards, I want you to watch some TV. And on Tuesday night, when everyone else goes to sleep, you're not going to go to sleep. You got to finish watching all my YouTube videos. Now, Wednesday morning, we're going to take the day off work and you and I are going to go for a 10-mile walk. And while we're walking and talking, we're going to discuss what it feels like to have MS fatigue. Now, if you are impacted by MS and you're picking up what I'm putting down, tell me in the chat. If that is an appropriate description to help a loved one understand what it's like to have fatigue, give me a thumbs up or something in the chat so that I know that you're on my page. Now, another chronic symptom of the up there's, if you will, is cog fog. Cog fog is super freaking frustrating, where as you get tired, as the day progresses, as you get overheated, you have increasing difficulties in processing. Now, this is not an Alzheimer's dementia where you don't know the names of your loved ones or you can't find your way home. This is, I can't move fast enough. I used to not need lists and now I can't find the list that I made. This is the leading cause of loss of work of MS. And the third of the triad of the up there's has to deal with mood. People impacted by MS are 2 times as likely to experience clinical depression. They are 2 times as likely to experience anxiety or anxiety disorders compared to the general population. And unfortunately, the data is very clear. Untreated depression or undertreated depression drives MS pathology faster. Now, maybe you didn't hear what I just said, and I'm going to repeat it. Undertreated depression makes your MS neurologically get worse faster, and we can treat depression. And so the up there's, the honey, you look so good that we have to address the invisible nature of fatigue, cognitive fog, and also dealing with mood are terribly important. And I want to make that point to you. So let's talk about how we're going to knock out one of those symptoms. The first person that writes in, whether it be fatigue, cog fog, or depression, that's what I'll talk about. So someone write down fatigue, cog fog. Okay, they wrote cog fog. So we're going to talk about cog fog. And in the spirit of a holistic approach to medicine, I'm not going to mention any drugs at all. I'm not going to talk about drugs to treat cog fog. And there are excellent drugs. But instead, I'm going to come up with, let's do 10 different ways that we can treat cog fog. Why did I pick 10? I have 10 fingers. So as long as I come up with one answer for each finger, then I'm in there like swimwear. So the first thing that we're going to do to treat cog fog is we're going to make sure that you're getting a solid 8 hours of sleep every night. Now, check yourself before you wreck yourself. If you're not getting an 8-hour sleep, you are not recharging your battery. You're not starting the day off the best that you could. You're robbing yourself of replenishing your energy stores, and you're starting your day that far behind. And so we need to make sure, number one, that you're getting the adequate amount of sleep. Many of us finish our day, we get the kids to bed, and it's 9 or 10 o'clock before the house is finally calm. And many of us, myself included, we demand some adult time. And what do? We sit in front of the boob tube and we passively watch television for a couple of hours. Well, here's my challenge to you. Go to bed an hour early and see what it does for your cognition in the morning. Number 2 of 10 things that we're going to list today is making sure that the quality of your sleep is good. And this is a real big one in MS. If you are a snorer and you periodically wake your wife up because you're snoring and you're stopping breathing, If you wake up not feeling refreshed, if you wake up with a headache, I am concerned that you have obstructive sleep apnea. And we have to address that, or we will never, ever successfully manage your cog fog for Rizzle. Now, if you have restless leg syndrome and you're laying in bed and you have a compulsion which builds up, and then you have to shake your legs for a second, that's going to keep you up, and that's going to interfere with the quality of your sleep. If you have an overactive bladder from MS and you have to get up not 1, not 2, not 3, 4, 5, 6 times a night, I have patients that wake every hour to go pee-pee, you are not getting restorative sleep. And if you have spasticity with spasms and cramps and Charlie horses that wake you from a dead sleep, rocking in pain, you're not doing everything that we could do to make sure that you're getting proper sleep. So number 2 is to make sure that the quality of your sleep is on point. Number 3 is to reduce polypharmacy. So doctors, particularly MDs, we are very, very good at giving you medicines, but we're not very good at taking them away. The average American with MS takes 7 medicines a day, which is a lot. And I challenge you to talk to your MS provider and say, hey, doc, is there anything that we can get rid of? Is there anything that we can cut in half? Do I really still need to be on this pill? Do I really still need to be on that pill? And I want you to look and see if there's anything that you can reduce. I challenge you that when your doctor offers to add a medicine, say, okay, fine, but which one are you going to take away? Because polypharmacy can contribute to cognitive fatigue. And just to flush that out a little bit, in specific, many of the bladder medicines that we use can interfere with thinking and memory, particularly the gotta go right now drugs, the anticholinergic drugs. Many of the medicines that we use for neuropathic pain, the medicines that were originally invented for seizures and now we use them to treat neuropathic pain, they can interfere with cognition. Even medicines for spasticity, which are terribly helpful in stopping cramps and spasms, can interfere with cognition. And so number 3 is to address polypharmacy. Number 4 is to exercise as part of your lifestyle. Now, there is very clear evidence in life that people that exercise maintain cognition when they enter into their 8th decade. But in MS, it's even more profound. And we can show data that people impacted by MS that exercise as part of their lifestyle maintain thinking and memory, and they slow brain volume loss. Now, maybe you didn't hear me. If you exercise, you preserve the reserve. That's a really, really big deal. And I think that was number 4. If it's not, I'm not trying to cheat. I just can't keep in mind all the different numbers. Number 5 is to make sure that you're eating real food. What is real food? Real food has ingredients like apple, chicken, broccoli. That's real food. I do not want you to eat fast food, fried food, processed food, sugar-laden food. And if you're looking at the ingredients on the back of a package and it has words you can't pronounce, that's not food, that's a chemical. And anecdotally, I can tell you that when you ascribe to a whole food, real food diet, energy improves, mood improves, and cognition improves. And if you don't believe me, I double dog dare you to try it and see what happens. Give it a month eating real food, not fake food, and see what happens. It is colossal. That is really good. Now, we've got 5 more fingers on this hand. So let's rock and roll with 5 more things that we can do to improve cognition. Here is a pro tip. Take a nap. If your lifestyle allows you 15 minutes to recharge your battery in the middle of the day, that can be life-changing. If you work a 9 to 5, but you have an hour for lunch, go to your car and sleep for half an hour and watch what happens. It is absolutely amazing how you can recharge your battery and think more clearly if you do the following. Take a nap. I'm being very, very serious. I want you to try it out. A nap is a powerful, powerful tool. Number next, I want you to get a pet. You're thinking, has Boster lost it? He wants me to get a pet because it'll help with cognition, but it actually will. Having a pet creates structure in your life. Because if you don't have structure in your life, your dog's going to poop in your house. If you don't have structure in your life, your dog's going to freak out because they're really hungry and they need to eat. And by having a dog, it's going to help you make sure that you wake up at a certain time because the dog's going to bark because they need to go out and go potty. It's going to make sure that you go outside, breathe some fresh air, go for a walk because you got to walk the dog. It's going to force you to be responsible because you have to purchase food or you have to make food to give it to the dog. It actually helps with thinking and memory. It can also help with mood. And let's talk about that one real quick. That'll be number 6. there's a concept called pseudo-dementia. Pseudo is a Greek word which means similar to but ain't. That's pseudo. Now, dementia, if we split that word apart, mentia means thinking, means I don't do it very well. So dementia means I don't think as clearly as I used to. In pseudo-dementia, it appears that you're having cognitive impairment, but you're not. You're depressed and it's undertreated. And if you can adequately treat depression, you can improve cognition. I do this on the daily in my clinic. Someone comes to me and they're not saying, I'm really, really sad. No, they're saying, I can't think clearly and I'm at risk of losing my job. And we put them on a medicine to treat depression, and guess what happens? It's life-changing. Oh gosh, guys, let's just say it's number 7. Number 7 is going to be drinking water. Many red-blooded Americans spend a tremendous amount of time dehydrated. And I have found over the years that my patients that take the MS Water Challenge fare better. They have more energy and therefore they think more clearly, for real. And so how much water should you have? Well, in my opinion, I want you to have 1 glass of water with breakfast, 1 glass of water with lunch, and 1 glass of water with dinner. I don't think that's asking too much. And then I want you to have a glass of water between breakfast and lunch, and a glass of water between lunch and dinner. All right. If you can do that, what you will find is that you're adequately hydrated. All right. Number 8 is to put a hard stop on fluids after the dinner hour. I want you to drink 2/3 of all the fluid you're going to drink in the first half of your day. And then I want you to put a hard stop after dinner. Now, don't walk around the house going, don't make yourself miserable. And if you have to take some medicine, take a sip of water. But what I don't want you to do is to chug water and drink fluids up until bedtime. Some people I know take a bottle of water to the bed. Well, guys, you make urine for 6 hours after you drink. And so if you go to bed at 11, 12, 1, 2, 3, 4, 5 a.m., all night long you're making urine, of course you're going to have to get up and run to the bathroom. All right. Now, why is that important? If you don't get good sleep, then you're not going to be able to think clearly in the morning. The last pro tip is to do your best work in the morning. I want you to be cognizant of the fact that as the day goes forward, you can have increasing difficulties with energy levels and increasing difficulties with fatigue. So if you're going to have a really important meeting, schedule it in the morning. If you have to process something on the computer that's really challenging, do it in the morning. There are 10 pro tips on how you can improve an invisible symptom in MS. Remember, we're talking about how to make MS boring. And one of the ways that we can make MS boring is treating an attack. A second way that we can make MS boring is by treating chronic symptoms. And I oftentimes think about the invisible symptoms, the up there's and the down there's. And today we focused our attention on the up there's. Now, the third way that we make MS boring is we slow down the disease. And so this is a really big one. I saved it for last. I have a saying that I want you to be 4 for 4 in your fight against MS. I want you to be 4 for 4 in your fight against MS. Now, you're at home and I'm over here, but on the count of 3, I want you to say out loud so everyone in your house can hear 4 for 4. All right? 1, 2, 3. 4 for 4 in your fight against MS. What does it mean to be 4 for 4? It means that there are 4 things that I'm familiar with that literally slow down the natural history of MS. And I want you to do all of them. The first one that I want you to do, number 1, is to exercise as part of your lifestyle. I told you a few minutes ago that exercise improves cognition in MS, which it does. But I also want you to know that people impacted by MS who exercise as part of their lifestyle become less neurologically disabled as they grow older. Allow me to repeat. If you exercise, you accrue less neurological disability compared to someone with MS that doesn't. That is a really, really big deal. And a commitment to exercise is critically important. To me, it's as important as taking a medicine. And you may be saying, well, that's lovely, Aaron. You know, when I was in high school, I used to run track or swim. Well, now I'm in a wheelchair. So how exactly do you expect me to do that? Well, there's a lot of ways. Today's program is being sponsored by an amazing organization. Let's give a round of applause to Yoga Moves MS. These guys are awesome, and they will help you do yoga despite having a neurological disability. You can jump on YouTube and find innumerable opportunities to exercise in your living room for free. A pro tip, the best way to do it, in my opinion, is in the pool. Throw on a life jacket, jump in the water, and try to get out, or take a walk in the water. In the water, you weigh less, and so your weak leg is less weak. It's carrying less weight. In the water, if you fall to the left, it pushes back to the right. In the water, if you get overheated, convection pulls the heat off your body. In the water, spasticity is markedly reduced. And so you can do things in the water that you can't do elsewhere. I'm going to give you a very, very personal example. I had the honor and the privilege to care for my high school algebra teacher. I met him when I first started as a professor many, many years ago. And he had primary progressive MS in an era where there was no treatment. Now, this was a really tall guy. He was like 6'8". He's a really, really tall man. And he was having increasing trouble, difficulty walking. So much so that he was using his walker less and less and less. And he was using his wheelchair more and more and more. And he didn't like that. His wife didn't like that. I didn't like that. Dogs didn't like that. And so we committed to a program of exercise. This guy went to the YMCA 3 to 4 times a week. He put on a life jacket. He put his walker in the water, and he literally walked laps with a life jacket on in the pool. Now, after 3 months of doing this, mind you, no medicines, he came to clinic, and the MA came and got me and said, Dr. B, he won't do his time 25 for walk until you come out in the hallway. So I came out in the hallway, and he stood there with this walker, and he said, young man, are you ready? And I said, yes. And he picked up the damn walker, and he walked 25 feet. He did that by sheer force of will and exercise, and you can too. And the first way that we can make MS slower in being 4 for 4 is to exercise as part of your lifestyle. This is really good. Now, number 2 is to supplement vitamin D. Vitamin D is a really weird molecule. It acts as a hormone, it acts as a neurotransmitter, and the data is compelling to me that people who have a low level of vitamin D are at increased risk to develop MS. And if you have MS already and you have a low level of vitamin D, that correlates with driving this disease much faster. Now, the data is clear that if we can drive your vitamin D 25 hydroxy above 50, but below 100, so I want it between 50 and 100, that correlates with good outcomes, less attacks, less disability progression, less MRI lesions. And so simply by supplementing vitamin D, we can slow down your disease. Now, if you have tuned in from Sao Paulo, Brazil, and you are a bronzed god, you might be getting enough vitamin D from the sun. But if you're tuning in from Northern Michigan and you're a pasty white kid, you might need to supplement your vitamin D. Now, how do you do that? You get a blood test and you check out whether or not your vitamin D is the right level. And if not, we supplement. And we do that all day, our day here in sunny Columbus, Ohio. And so the second way that we can slow down your disease is simply by supplementing vitamin D3. Now, the third way that we make MS boring is we don't smoke things. I don't want you to take a carbon-based material, light it on fire, and then suck in the smoke. I'm talking about tobacco. I'm talking about ganja. I don't want you to smoke things. Smoking increases the risk to develop MS. Actually, it doubles the risk to develop MS, which is insane. But if you have MS, it speeds up your disease almost by 50%. Allow me to repeat. Smoking cigarettes speeds up your disease by 50%. Now think about this for a second. The early MS drugs that came out in the 90s could slow MS in some ways by about 30%. You can speed up MS by smoking cigarettes by 50%. And here's the kicker. If you quit smoking, you slow it back down. So the effect size of smoking or not smoking is actually bigger than those ancient drugs that we used to use to slow down the disease. That is a really big deal. So when I talk about being 4 for 4 in your fight against MS, I'm talking about exercising as part of your lifestyle. I'm talking about taking vitamin D supplementation to drive your level above 50. And I'm talking about not smoking stuff. Now, the fourth way to slow down MS, as we're 4 for 4, is to take an MS disease-modifying therapy and make sure that it's working. Now, there are 22 FDA-approved therapies, and we just had an awesome rock star lecture from a really, really great neurologist who shared with us a bunch of the latest and greatest. And it is not my plan here to tell you the faves and the goods and the bads, not at all. Here's my point. We want to make sure that your drug's working. And the drug that's right for you is the one that allows you to achieve NETA-4. What is NETA-4? NETA stands for no evidence of disease activity, or if you're Spanish speaking, NADA, no apparent disease activity. And during the time period that we're looking at, we have a goal. We have a goal or a target of no attacks, no new spots on MRI, no change on the neuro exam, and normal rates of brain volume loss. That is our target. That's what we're shooting for. Now, the likelihood that we achieve that with the disease-modifying therapy your whole life is not very high. And so at first blush, you might say, well, Boster, that's kind of a stupid goal if you can't achieve it all the time. And I would say, no, that's not right. We have to think about it a little bit differently. And let me give you an example. So in non-COVID times, in March, apparently there's this really big college basketball tournament where all of these basketball teams have this giant tournament, and then there's a big winner. And at the beginning of the tournament, 64 different coaches tell 64 teams of young men, boys, because that's the way coaches talk, boys, this is our year. We're going to win national championships. And you might say, well, then 63 coaches are darn liars because only one team gets to win. But that's not true. What the coach is actually telling his team is that they will conduct themselves like champions. They will conduct themselves like champions. They will eat like champions. They will sleep like champions. They will attend class like champions. They will practice together like champions. And if they come in second in the nation, they still get a prize. They have set a target. Now, if they start the season and they lose the first 2 games of the season, the coach doesn't disband the team and quit his job and sit at home and listen to The Cure and cry. No. He assesses what's going on, he makes some changes, and then they go back out and they play again. And that is exactly what we do with NETA-4. The reason I like this concept is if you're taking a drug, whatever disease-modifying therapy that is, and you have an attack, we know that's not okay. If you have new spots on your MRI, we know that's not okay. If you're having a failure of the litmus test of life, what is the litmus test of life? That's where you're backing away from life because of MS. Now I have to stop. Julie just said that's an interesting photograph or picture. And I want to thank you, Julie. My grandfather, Irv Levy, was the care partner of my uncle with MS until his dying day. And he painted that. It's an honor that I get to have it in my house. It's a painting that I've looked at my entire life, and I'm really, really excited to share it with you right now. So thank you for asking that, Julie. But I was talking about taking a disease-modifying therapy and make sure that it's working. And the reason that I love having NETA as our guiding light is we can assess. Every neurologist on earth can tell you attack versus no attack. They can tell you whether you are having disability on your exam. They can tell you whether you have new spots. And that is how we're going to sort out whether we're winning or not. And if you are having breakthrough disease, that's not okay. So as we think about life in 2020, and we get very, very excited about future neuroprotective agents, and we get very, very excited about remyelinating agents, I also want us to realize that in the now, you have the power, the ability to make MS boring right now. How do we make MS boring? We treat attacks aggressively. We treat chronic symptoms aggressively. And we make sure that we are 4 for 4 in our fight against MS. My name's Aaron Boster, and I want to thank Yoga Moves MS for this opportunity to educate you. And as always, I want to thank you for learning about MS with me.
Dr. Boster, thank you so much for a lovely presentation. Again, we've heard from 3 stellar MS physicians, and this is a beautiful group you put together, Mindy. So thank you, and Aaron, again, beautiful work. We love what you're doing. Keep it up. Before we get, Mindy's going to introduce the next speaker, but I just want to say a quick thing. You know, adaptive yoga just isn't for MS. Last year, Mindy began a course with the Michigan Parkinson's Foundation. We now have a very large class there. And yesterday, my wife called me into the room. She was watching a TV show on opioid addiction. And there was this poor soldier, double amputee, hooked on opiates. Life was ruined. And he said, the craziest but most important thing someone said to me is, you need to do yoga. And there he was trying to do yoga. And he learned that his devices, his artificial legs were just getting in the way. And he learned, don't be embarrassed by them. And he doesn't. He does yoga without his devices, and it's changed him. He is no longer addicted. He manages his pain. So beautiful thing. So thank you, Dr. Bostrom. Mindy, I'll let you take it over to introduce Paige.
Yay, thank you so much. Thank you, Paige, for switching order to accommodate schedules here. Your topic is so popular, though. So
I'm excited to talk about it.
let me just tell them a little bit about you. Paige Goulet. She's currently a neurology nurse navigator at Memorial Healthcare Institute for Neuroscience in Owasso with Dr. Rani Abu-Rashad, who you heard from. Paige earned her bachelor's degree in health science at Grand Valley State University and continued her education at U of M for her bachelor's of nursing. She quickly realized that her education and work in various specialties, how important the mind, the body, and the spirit work together. We are so on the same wavelength. Through her patient, personal, and family experiences, she developed a strong belief in how diet, exercise, and mindfulness and meditation can make a positive impact on providing complementary care, especially to the MS population. The MS community has made such a huge impact on her life, her career, and it's pushed her to start the Doctorate of Nursing program so she can better serve patients in this specialty. She's very excited to see what the future has in store for these patients and how we can better help them. Now she's going to talk to you about diet and nutrition for MS. Thank you, Paige.
Thank you. All right, like she said, my name's Paige. I'll be going through the diet and nutrition portion for MS, and I work with Dr. Rani, Dr. Pace, and Dr. Cody at Memorial Healthcare in Owasso, Michigan. So if you want to go to the next slide, we'll go from there. So diet is a super complex topic, just as medications are in MS. I feel like diet, exercise, mindfulness, like Mindy mentioned, is extremely important in MS management, and it really can take hours to go over with each individual patient that's tailored to each patient, just like medications are. But hopefully I can give some clear-cut points to help better manage some of this and what we use in our clinic and what I've learned through research in terms of diet and nutrition. So we'll start with where to start. You can go back to the last slide, actually. And 4 different things I just want to point out just when you're starting to think either about changing a diet, or even if you're just looking at diet and nutrition for the first time, or you have been newly diagnosed, is 1, to keep your team in the loop. So always make sure you're informing your MS team of any diets or protocols or food changes that you may be making, just like you would if you were starting or stopping a medication. It may have an impact on your MS condition, so it's important for you to share that with your neurologist, with if you work with a dietitian, obviously that's something that they're going to know about, with your primary healthcare provider or any other specialist that you might see. So always keeping them in the loop is a big thing, whether it can cause positive or negative benefits to you and your MS. We want to know that you've started something new. The second thing is knowing your resources and knowing your sources. So before you start or implement any major dietary changes, it's important that you know your go-tos, knowing that they're credible. Because if you go on Google right now and search MS diets or food for MS, you're going to come up with a whole slew of results. Then you want to make sure you can trust what you're reading and that it's going to make a difference, or know kind of what's real and what's not. So you can go to your neurologist to ask questions. You can go to a healthcare professional you trust, a dietitian, or make sure if you are reading things online that they're scientifically based, or that they're evidence-based trials, because that's really how we gain our knowledge on this, and how we gain things from medication and diet and exercise. So making sure it's scientific based. And third is to keep it simple. So there are multiple complex diets out there, not just for MS, but for other conditions as well, but for MS too. And they involve a lot of do's and don'ts. So if you're at least able to take one thing away from this, and to keep one thing in mind, it's are you eating clean and are you eating fresh? So every time you eat something or every time you start a meal, is it clean and is it fresh? So if you're able to, and we'll elaborate on that a little bit more, but if you're able to answer that in terms of eating fruits, vegetables, lean meats, unprocessed foods, things with little additives, you may find yourself eating better already if you can ask that question right before, instead of carrying around a list that has 12 foods that you are supposed to eat and 15 foods that you're not supposed to eat, because it can get a little complex there. And lastly, if you can change your mindset from diet to lifestyle. So when you're thinking of these changes, lifestyle is a way in which somebody lives based on values and beliefs. And it's just something more so a routine that you follow each day or something you follow throughout your life, versus a diet where you're really restricting things and limiting specific foods to either achieve weight loss or things like that. So really changing this to more so a lifestyle that you just live on a normal basis. We can go to the next slide. So the next thing is, why does food matter? With anything that we do in life, you can think that what you put in is what you're going to get out. So that can go with work, that can go with relationships, that can go with food. And so when you think about what you're putting into your body, if you're putting in junk food, processed foods, sugar, a lot of sweets, things like that, you can probably expect to not get the best outcome. But if you're putting in fresh foods and clean foods, then you can sometimes expect more of a better outcome, or what your body is going to put out. And just to take away from this, that food as of right now really just aids in helping with the management of symptoms and of MS. It's not here to replace your disease modifying therapies for right now. So if you're on a disease modifying therapy, this presentation isn't meant to say, hey, let's follow a keto diet and have you stop your Mayzent or stop your Ocrevus to do a Mediterranean diet. It's more so to use as a complement to what you're already doing. And some research trials have shown that a higher quality diet can have a higher quality of mental and physical quality of life, and can help better manage symptoms associated with MS, such as fatigue, mood, or depression, bowel dysfunction, which we'll go through a little bit in the next slides. And we can go to the next one. I think there may have been one missing in between, but I'll kind of go through. There we go. So what diet to choose? Just like when you go to your neurologist, whether you have just been diagnosed with MS or you've had it for a while and you've been on a certain medication, and you go to your neurologist and they end up switching you, the way that they pick which medication they put you on is typically research-based and has gone through trial after trial after trial to show that it's effective in what your end goal is. And the same should go for diet. And so we need to make sure that we're relying on good research and good levels or high levels of evidence for diet. And unfortunately, there's not one diet that cures all for MS or one diet that is perfect for every patient. But there are some research trials that have been shown that some diets may be a bit more effective than others. And that's why those ones at the bottom are in bold, and we'll elaborate on those ones a little bit more than the ones that aren't in bold. But trials in diet and MS specifically are hard to conduct for multiple reasons. It's very expensive to do research and to do research on diet specifically. A good trial has randomization and it also has blinding. So you want your investigator, the person running the trial, and the participant, so the subject or patient, to both be blinded. And with diet, we most likely know that's not possible. So if you're getting a specific diet or not getting it, you're going to know, and your investigator most likely will know, but it's hard to double blind there. And then also large sample sizes help with the higher levels of evidence, and that's a hard thing to do with diet trials. People have a hard time adhering to diets, and that can sometimes skew results. And also, if patients aren't put in the category or the diet that they would prefer, that sometimes can cause some early dropouts or withdrawal from the trial. So there's a lot of different factors that can go into affecting the credibility of a research trial and its results. So that's why we haven't probably heard of one diet that's administered or provided to every single MS patient. So we can go on to the next slide and get more into them. So the Swank diet is one that's probably been around the longest. It came out in the 1950s and initially started with a study tracking 150 patients with MS. And over multiple years, for decades, probably until the early 2000s, they tracked these patients and they did find that there were less exacerbations of MS in relapsing MS, and also that there were less severe exacerbations. And so over decades of that, of following this low-fat diet where these patients were limiting saturated fats, they did have good results in that sense, but there were a lot of limitations to this study. And so that prompts physicians to maybe not use them as much because we don't know if those results are credible. So this is one that a lot of patients will still report that they've used with MS, but not necessarily the biggest one, at least that our providers usually suggest, just because of all the limitations on them with their research study. So we can move on to the next one so we can get to the ones that we do have information on. And then the next one is the McDougall diet. And this one is a plant-based, very low-fat diet, vegan, which eliminates all meat and all animal-based fat. So dairy products, fish, eggs, and while some of this or components of this diet are appealing that we'll get into at the end of this presentation, there is little evidence that following this diet strictly has had positive impact or research proven evidence on MS symptoms or MS management. But I know they did have a recent trial that showed there was not a difference in relapse rates or lesions on MRI with this diet. They did have some improvement in fatigue, but they kind of related that more so to weight loss with the diet. And so, like I said, another one that isn't necessarily recommended in our clinic either. There is a trial going on with this diet right now, so it will be interesting to see what that entails or what that shows later on. And you can go to the next slide. I lumped all these ones together. So for gluten-free, Atkins, low sodium diets, and strictly high-fat diets, a lot of the research that's been compiled hasn't shown any proven data on MS management or improvement in MS management with these diets strictly. So a lot of the other diets that we will talk about, they include gluten-free. So they will incorporate that in it, but also will have other things on it. So for people who are gluten intolerant or have celiac disease, obviously you're not going to consume gluten, and that will fall into another category. But when they say gluten-free, just solely gluten-free, they don't have any proven data that that is going to improve MS symptoms or management of MS. And we can go on to the next one. And there is actually a couple trials going on right now looking at high and low sodium diets and modified Atkins diets. So we will see what those show as well. So the keto diet, this is a huge diet that's come out recently, not just in MS, but in a lot of different conditions, but it's a high fat and low carbohydrate diet. And it really focuses in showing, the research has shown anti-inflammatory properties of this diet, as well as neuroprotective properties of it. And so there are good fats that we talk about, and on the next slide we'll talk about food specific to this diet, but high good fats or amounts of good fats, so animal protein, plant protein, omega-3s that you'll find in fish and nuts and oils, have shown improvement in fatigue in MS. And so there are current trials going on with this as well. But there are some potential negative effects to be aware of with this diet also, in that weight loss, which can be a positive thing too, but if that's not something you're aiming towards or looking for, that could be a potential negative side effect. GI upset, an increase in your lipid levels in your blood, and it's also been shown to be harder to adhere to or stick to because of the strictness of the diet. So we can go on to the next slide and look at what foods fall into this category. So these are the main food groups that go into the ketogenesis diet. And if you're going to follow this diet, at least with the meat and the seafood aspect of it, following the meat portion of it, and this is something, like I said, you should go over with your neurologist, potentially a dietitian, or somebody that can tailor this specifically to you. But meat, the biggest thing with all these foods is making sure that they are high quality. So you can say, yes, I'm following a keto diet and I'm eating cheese for breakfast, lunch, and dinner. And it falls into the keto food group. But you're still not getting all of these other nutrients that you need. And so making sure you're eating high quality food and getting food from all of these different examples that I'm giving here. So meat, if you're able to afford it, or when you're able to access it, you're getting grass-fed beef or meat versus grain-fed, looking and making sure that it's not genetically modified. And then when we move on to seafood, looking at foods like salmon, if you're able to aim more towards that versus something like tilapia that we've read in research has higher mercury content or higher content of heavy metals that we don't necessarily want to suggest that either. So, and then eggs, cheese, nuts, butter, oils, low carb vegetables are, you're going to want to try to avoid high carb vegetables in terms of potatoes. Beets are something that are higher carbs but have other potential benefits. And then corn will fall in the high carb category for vegetables. And then this focuses a lot on small amounts of fruit because of the sugars that are entailed in there. So we'll go on to the next one. Calorie restriction and intermittent fasting. This is a big one that one of our neurologists, Dr. Pace, talks about and recommends and actually does on his own in the clinic. It can be complex, more at a cellular level is where a lot of the research has shown this. It makes an impact on MS patients. But it's anti-inflammatory. It has some neuroprotective benefits from it, and research has shown increased health-related quality of life from the subjects and participants in those trials. And there are different variations of intermittent fasting that we'll go over, but one of the biggest analogies I can give on this is if you are at work all day and you're working an 8-hour day, and your boss comes to you at the end of the day and asks you to stay an extra 4 hours. So you stay an extra 4 hours, and at the end of that shift, he comes to you again and asks for you to stay another 4 hours. So now you've worked 16 hours and you haven't taken a break, you haven't gone home and taken a nap. And then he asks you to stay through the night. And so you're working almost a 24-hour shift without any rest, without going home and giving your mind and your cells your cells in your body to recuperate and reset, essentially. The same thing can go with our cells in our bodies. So we're constantly feeding them over and over and over again, making our body work over and over and over again for an extended period of time without giving them adequate time to rest and reset. And so that's important in intermittent fasting, giving our body and the cells in our body time to relax, reset, and rest. And so this diet's not for everybody. If you have other comorbidities, if you have diabetes or other underlying conditions where fasting or restricting your calories isn't an option, then obviously, like I said, that's why you want to keep your healthcare team in the loop. And just a little motto to live by, but eating to live, not living to eat. So we want to eat in order to survive. We don't want to spend our days eating all day and living to eat. So just something little to think or remember. So the different variations of intermittent fasting, the ones with the stars are the ones that our neurologists recommend the most. So time restricted, limiting food intake to a 4 to 6 hour window. So you'll go during the day, you'll eat for a 4 to 6 hour time period, and the rest of those hours you'll give your body a break. And the 5 to 2 diet is fasting for 2 days per week, and the rest of those days, the 5 other days of the week, you will eat normal. And so when you're starting out something like this, or you're talking to your neurologist or a dietitian about potentially trying something like this, you can start, a lot of people start at a 16 and 8, 16 hour and 8 hour fasting technique, and that's where you'll rest, not eat for 16 hours, and then you will eat for 8 hours. So you eat from 11 to 7, and then you rest or don't eat from 7 to 11 the next day. And when I say rest, I mean not eating, not necessarily resting yourself, although that would be nice. And then there's other variations of this in every other day fasting. So every other day, you will have something to eat. The next day, you won't have something to eat. And then the other one is reduced calories. So this is just an example, but reducing your calories to 500 calories per day for specific days of the week. And then the other days, just eating normal. I'm gonna go to the next one. So the Wahls diet, that's a huge one. I know it's Terry Wahls that a lot of MS patients have read the book and can adhere to this diet. And the Wahls protocol is considered a modified paleo diet that follows a diet rich in fruits, vegetables, lean meats, and fish, which is in low intake, while avoiding other food groups that are mentioned on there. So avoiding dairy, eggs, gluten, highly processed foods. They get really down to the nitty gritty in avoiding nightshades, which are things like peppers and tomatoes, eggplants and white potatoes. And so there's a lot of specifics to this diet. And the main one that came out, there was a case report, which is a lower level of evidence as far as research goes, that showed regression of disability from somebody that was wheelchair dependent, so in a wheelchair, to mild gait disability, so that they were able to walk again. And this study also involved a lot of other components. So it looked at, it included exercise, some stimulation techniques, supplements, and so there were other things that went into this. And this also was a case report. It wasn't a randomized, controlled, blinded study. Like I said earlier, is really the highest level of evidence. So we don't necessarily at our clinic use this as a general rule for suggesting this diet to everybody, but there are a lot of benefits to this diet too, because we, as Dr. Boster said, avoiding highly processed foods, avoiding fast foods, fried foods is a big thing in MS as well. So this study, just a couple other, I guess, research points on it. There's been small groups of patients that have participated in these trials with this diet, and there are trials going on right now with this. So like I said before, there's going to be a lot of emerging data that comes out, hopefully with some of these diets, but improved fatigue and quality of life in some progressive MS patients with this diet, but it also was a small cohort that they used, and they used a lot of different exercises, meditation, and supplements that complemented it together. So potential for improved cognitive function, mood, fatigue, quality of life, but there's a lot more data that needs to be shown on this. And like I said, there is a current trial going on with this diet as well as the Swank diet, in comparing them together and really looking and honing in on fatigue. So that will be really interesting to see that, the results from that one. We can move on to the next one. So the Mediterranean diet, I did the nutrition clinic for Alzheimer's as well. So I know that's not our focus today, but this is one of the biggest diets that we focus on with cognitive aging also. And there's a lot of neuroprotective factors that have research based behind this. And so it's an interesting diet. And I know there's some questions coming in too, which I can either address at the end of this, or I can answer questions after the whole presentation is over too. But the Mediterranean diet is low in saturated fats. It's high in fruits and vegetables, low in processed foods. So we see that one consistently across a lot of diets. And so that's one thing to definitely take away, and we'll go over that one in subsequent slides. But it has been shown to have reduced MS risks. So for at least developing MS, which I know doesn't apply to a lot of us here, and then also higher quality of life ratings than control groups that were compared to this Mediterranean diet. So we'll go over example foods in the next slide, which we can go to. So olive oils, fruits, vegetables, nuts, and when I focus on fruits, really berries are going to be the biggest thing. So they have a lot of antioxidants in them. If you look at fruits that are very high in sugar, so bananas, dates, mangoes, and raisins. Not to say you can never have them, but when we suggest fruits, it's more so leaning towards berries, strawberries, raspberries, blackberries, the blueberries. Those are what we will focus on more with fruits. And like I said, vegetables, nuts, whole grains, and then they go into moderate and low intake of specific foods. So this one doesn't completely eliminate anything necessarily. So it still recommends fish, poultry, and wine is on here, which is kind of nice. And then it has a low intake of dairy, red meat, and sweets. And so dairy does have an inflammatory factor to it. So that's something that we don't necessarily recommend having high amounts of. And we'll get into sweets and whatnot on the next slides. And there is actually a current trial going on with the Mediterranean diet as well. So that will be interesting. It focuses a lot on specific types of olive oil. And so that will give us more of an insight on what we can recommend with that. But for right now, they really focus on extra virgin olive oil. And if you're able to get organic, that's great. But just really focusing on extra virgin olive oil versus something like vegetable oil or things like that that don't have as high of a level of antioxidants in them. So we can go to the next slide. So I know those diets all have a lot of components to them, and there's not one that I'm saying, hey, go home and get a book or two on a Mediterranean diet and stick to that, and it's going to prevent everything going on with your MS, and it's going to improve everything. But if we can take away some foods to avoid, I know they touched on this a little bit in previous presentations, but processed foods are a huge thing. And I think one food that a lot of people don't put into this category is lunch meat. So that has a ton of sodium in it, a lot of additives and preservatives to it. And really, any packaged foods that have those preservatives and additives in them are probably not things to put in our body. So really avoiding the processed foods is a big thing. Large amounts of dairy, sweets, pop, and soda, or pop or soda, whatever you would call it, depending on where you're from. But large amounts of dairy have a pro-inflammatory component to it, and so does sugar. And you'll find that in research everywhere, not just in MS, but in other conditions as well. So I know it's easier said than done to avoid sweets, but if you're going to eat a sweet, try to look for something like a dark chocolate, or something along those lines, instead of going and getting a package of Oreos. And I think Boster touched on this a little bit too, but if you look on the back of a package and there are a list of a bunch of foods or ingredients that you can't pronounce, don't buy it and don't eat it. And it's, like I said, easier said than done, and you want to treat yourself once in a while too. But if you're really focused on sticking to a specific food lifestyle, try to avoid foods that you can't pronounce. And then more than 5 won't help you thrive. And this is a hard thing to stick to too, but if you can look at the back of your ingredient list, and if there's more than 5 ingredients, if you can follow that rule to try to avoid foods that have more than 5 ingredients on the back of them, that just aids in other management of things like we talked about earlier. So we can go to the next one. So I have mentioned throughout this whole thing, when we get on each different diet topic, is that there is a current trial going on with this diet or with this specific symptom. And so anybody that is interested in looking at either current diets that are enrolling for trials, or ones that are going on but aren't currently enrolling participants in, you can go to clinicaltrials.gov, and if you put your search terms in there, that multiple sclerosis and diet, then you can see kind of what they have going on there. And we can kind of go to the next slide. Just a couple tips and tricks. So if you're able to go grocery shopping and stick to the perimeter of the grocery store, avoiding those center aisles is where you'll avoid the processed foods with additives and preservatives to them. So if you can try to go on the perimeter of the grocery store next time you're there, instead of going to the center where the chips and snacks are, that's a big thing. If you're able to make homemade dressings and marinades, that can eliminate a lot of unneeded sugars or ingredients that are thrown in there that we don't necessarily know of. And Dr. Boster touched on water, so I won't go too much into that. And if you are on a budget, there are a couple different resources I've added in there, and I know we're kind of running out of time. So that's something that I'm completely willing to go over with people after the presentation or at a separate time, so we can touch on that, because I know it's sometimes expensive to shop healthy and to eat healthy. And we can go, I think, Mindy, did you want me to touch on the recipes specifically, or?
We can put those in the exhibit hall for people.
Okay.
And then they'll...
And I have a handout as well that we can upload there. So it'll have the instructions on everything and give some direction on how to make those and kind of what they fall into. But there's just some different options in there.
Paige, can you look at the questions in the chat?
Yes, let me look. Sorry, I know there's a few that came through. So
hard to keep track.
Let me see.
they're not staying on.
So I'll touch on, I know there's a lot here, so I would want to, I do want to answer them all. I don't know how much time everybody has, but, and if I can't specifically answer some of them here, I can always take them later too. But the thoughts on a vegetarian diet. So as far as, I know I keep saying this from a research standpoint, but that's really where we get our solid evidence of what we can and can't recommend. But there isn't anything necessarily showing that that meat is bad. I think it's more so the quality of the meat if you're going to eat it. It does provide us with a lot of benefit too as far as protein. But like I said earlier, the quality of the meat is probably more important than, or the quality of the fish is more important than completely eliminating it from our diets, at least from what our MS providers instruct and what we have found through research and research-based articles. So that's the vegetarian one. Let's see. As far as the dairy for MS, dairy, regardless of if it's MS or other conditions, it does have an inflammatory component to it, and that's been shown on a cellular level as well as other inflammatory diseases as well. So I don't think necessarily having to completely eliminate it from your diet, but being mindful that it is an inflammatory food, and so that's something that we can see in research. And supplements, along with any diet, I think the supplements would be something to address specifically either with your neurologist on a personal basis or with a dietitian on a personal basis, just because it's a very broad topic and not something that one size fits all or one thing fits all. So I would say that would be something to address specifically with your neurologist, so it can be a more tailored to you specifically. I like the trivia question about the cats.
Gotta add a little fun in there.
Yeah, exactly. Which diet do we use in our clinic? I would say the biggest thing that's recommended by all of our neurologists, they're all very big on intermittent fasting, which I know, like I said, can't be applied to every patient because of other, maybe some other comorbidities, or it's not for everybody. But I think with all three of our neurologists and what we recommend, the biggest one would probably be intermittent fasting and the Mediterranean diet. And that goes from MS to, like I said, Alzheimer's as well, that we do the clinic with. Let's see. Are there any other ones, let me see, that I'm missing?
Creatine, did you see that one?
Oh, creatine. As far as, let's see.
It says, is creatine okay?
As far as like a supplement or a protein, or in
Not-
what con?
I would guess it would be a supplement.
I would say a supplement.
So I would say with that one, like I said, with the supplements, I would directly talk to your neurologist or a dietitian specifically about those, just because the creatine, I think, would be something that would be addressed on a personal level, not everybody altogether. And the intermittent fasting diet why is the intermittent fasting diet recommended? So this one, like I said, giving our cells, and it can get a lot more complex on a cellular level, but giving our cells chance to reset, and it has shown anti-inflammatory components to it and neuroprotective factors to it. So that's one of the biggest reasons our neurologists recommend the intermittent fasting diet. It's had a lot of research shown behind it.
I think that looks like it. People are welcome to put more in the chat. We can get answers to you if you have more for Paige. And her recipes will be in the exhibit hall. We're putting in the exhibit hall link in the chat, but it's also in the letters that you all received, and you'll get a follow-up letter with it as well. And it will be on the Yoga Moves website. Okay. Dr. Voci, did you want to say anything?
Mindy, thank you for putting together an excellent program. I mean, I've been getting nice text messages from lots of people. This was a very nice presentation. I want to reach out to that Rhonda in California, who said a very nice thing about how with the pandemic, she's forced to be at home, and this is the best presentation she's seen on MS. So thank you. It's great that we got people from out of state. That's beautiful. So listen to the words of wisdom today and go forward and make tomorrow a new start to a better and healthier life. So thank you, everyone.
Thank you, Dr. Voci. Thank you so much for your leadership. And I think Dr. Rani said, your heart is in it. And even if you're not, you don't have to be engrossed in the details. We take care of that. You just kind of give us a little tug and we're off. Thank you so much to our amazing panel of speakers. Our very generous sponsors, all of those that helped to spread the word. And I really couldn't have done it without our fantastic planning committee. So thank you again to our committee. So everything will be in the exhibit hall. If you have any questions for our sponsors, bring them on. We will get them to them. And you can actually hit on some of their links and go directly to some of the sponsors. Thank you so much. Congratulations, trivia winners. We will get your addresses and send you out your prizes. Take care, everyone, and fill out our survey when you receive it. Bye-bye. Enjoy your days.